I welcome each and one of you delegates who have come virtually to this program for a rich academic feast. As the Upanishads say, let noble thoughts come to you from every side. Let knowledge and wisdom come to you from every side. Let the knowledge and wisdom you cull from this program be of benefit to the hundreds and thousands of children whom you are going to treat. Thanks. I now request Dr. Nammalwar sir to take over from me.
Thank you, Kannan sir. I'm very happy and I offer my respects to our Guru and great teacher, Professor B.R. Nammalwar, requesting him to deliver the inaugural address. Professor B.R. Nammalwar is a senior pediatric nephrologist and former professor of pediatric nephrology, Institute of Child Health, Madras Medical College. He is the first pediatric nephrologist of this part of the country. Dr. B.R.N. is the founding father of pediatric nephrology. Through his characteristic combination of academic excellence and mentorship, he has inspired generations of pediatricians to provide service to children with kidney diseases. The Indian Society of Pediatric Nephrology presented a Lifetime Achievement Award to Professor B.R. Nammalwar for his outstanding contributions to the care of children with kidney diseases. After his retirement from Madras Medical College, he established the pediatric nephrology centers in Kanchikamakodi Child's Trust Hospital and also in Mehta Multispeciality Hospital. Apart from providing clinical services, Dr. B.R.N. is an educator par excellence. He is known for his remarkable teaching skills among the pediatricians and adult nephrologists alike. Professor B.R.N. founded the Kids Kidney Care Trust to spread the awareness of pediatric nephrology among community physicians. He has received multiple awards for teaching by his parent institutions, state level and national level bodies, such as MGR University, the IAP and IMA. His textbook, The Principles of and Practice of Pediatric Nephrology, written entirely by pediatric nephrologists in India, is a key reference manual. He has also published many scientific articles in national, international journals and has been invited to deliver numerous prestigious orations. He is also an emeritus editor of Popular Indian Journal of Practical Pediatrics. Most of us are indebted to him because he mentored all of us. We are here in this position only because of his teaching abilities. He not only learned pediatrics and nephrology from him, also ethics, commitments, hard work, and compassionate attitude to the sick kids. Over to you, sir. Professor B.R.N. sir, we request you to deliver the inaugural address.
Sir, can I take
B.R.N. sir?
Dr. Kalevani?
Unmute button. Thank you very much, Dr. Tangvelu, for such kind words about me. I'm really honored to be invited to inaugurate this IPN Endorsement Webmaster Series 2022, a Pediatric Tubular Disease Symposium. This webmaster on kidney tubulopaths follows an academically successful and internationally welcomed webmaster series on kidney glomerulopathy in 2021. The present series will be 2 per week program on Wednesday and Saturday, Wednesday and Saturday, starting at 6 p.m. and would end in August 17th. I'm very happy to say the topics are so aptly chosen, and the faculty are so well-known academicians. They're not ordinary people, they're out of the ordinary. We are really fortunate to have them to participate in our symposium. I'm sure this webmaster series will be an academic feast as the earlier one. I congratulate Dr. Kalevani and our mentor, Dr. Tangvelu, for their commendable work. I wish them all a great success. Thank each one of you for giving me the permission to inaugurate the session. Thank you.
Thank you so much, sir. Now I request Dr. Gauri Shankar, sir, Head Department of Pediatrics, Clinical Operation and Quality and Pediatric Pulmonologist of Mehta Children's Hospital, to welcome the gathering.
Thank you, Dr. Kalevani. I have been given the honorable task of welcoming so many stalwarts in the field of nephrology. First and foremost, it's going to be Dr. Edwin Fernando, who is the professor and head of nephrology and renal transplantation, Government Stanley Medical College, who is also the senior consultant nephrologist, Mehta's group of hospitals. And I'm proud to say that we all studied our undergraduate together, though he was 6 months junior to me, probably like from 1984. We have been with one a thick friend and a guiding force in so many programs. I welcome Dr. Edwin Fernando. Next will be Dr. P. Soundararajan, who is a nephrologist who had faculty position right from lecturer to head of the department. He had served for 25 years as professor and head of department of nephrology, guiding so many postgraduates in internal medicine, postgraduates of internal medicine in nephrology. He has had 15 PhD scholars under him, and he had so many awards, including Dronacharya National Award in Nephrology, Lifetime Achievement Award from Dr. MGR Medical University. I welcome Dr. Tej K. Matu. He is a professor of pediatrics and urology, vice chair, Department of Pediatrics, Wayne State University School of Medicine. He is a pediatric nephrologist, and he has many publications to his credit. And more than that, editor-in-chief of Up to Date. Dr. Susan Uthap, my warm welcome to you. She is the president of IPNA, and we know that her interest in pediatric nephrology, especially pediatric chronic kidney disease and dialysis, is well known throughout India. I welcome Dr. Aditi Sinha, who is the secretary of IPNA, who is in All India Institute of Medical Sciences, New Delhi. I extend my warm welcome to Urimala Anand. She is the president, Women in Nephrology. Dr. Manjusha, who is the secretary of Women in Nephrology, and Dr. Swarnalatha, who is the treasurer, Women in Nephrology. I also extend my warm greetings to Indian Academy of Pediatrics, Tamil Nadu State Chapter President, Dr. Ramesh Babu, and Indian Academy of Pediatrics, Chennai City Branch, Dr. Eril Arasi. Over to you, Dr. Kalaivan.
Thank you so much, sir. Soundarajan, sir, would you like to say a few words?
Respected senior colleagues and rising star in pediatric nephrology, Dr. Kalaivani, I am so immensely pleased to speak in presence of my revered guru, Dr. Nammalwar, and along whom I had the fortune of studying DM nephrology in Madras Medical College. And I have no words to express, say that Mehta Hospital and the pediatric nephrology department is doing a great service to update the skills in pediatric nephrology for the benefit of all of us. We are immensely pleased to join with you and appreciate you. And I request you to take forward these 2 years to come in a printed form for the benefit of all our young postgraduates. I think it's my great desire and pleasure that pediatric nephrology should grow as much as the other nephrology in this country in the years to come. Thank you very much for the opportunity.
Thank you, sir. Tej, sir, would you like to add a few words?
Did you ask me or?
Yes, sir. Would you like?
I'm sorry. Maybe my audio is not that good. Well, I'm delighted that you are doing these webinars, and I know last year it went very well, and then again you are doing it this year. And as you see, there are plenty of Indians and non-Indians all over the world who want to collaborate with you for these webinars, and I'm very happy to participate in it, and I wish you the best of luck. Thank you.
Thank you so much, sir. Susan, ma'am.
Yes.
On behalf of ISPN, would you like to gather the?
Yeah. Good evening, everybody. It is indeed a pleasure to be attending this forum on behalf of the Indian Society of Pediatric Nephrology as the President of Indian Society of Pediatric Nephrology. Actually, COVID has actually given us a lot of good things as well as bad things. And among one of the best things that happened over the last 2 years is this virtual platform, which has helped us to learn a lot. And Mehta's Children's Hospital and the team has been already, they are a trendsetter in this virtual learning program that previous glomerular symposium, which you were having. It was actually indeed a great success. And I'm sure that this webinar, IPNA sponsored, IPNA endorsed webinar, as well as the ISPN endorsed this program on tubular disorders, which is actually, will be going to be an enriching experience for all the learners throughout the world. And I wish you great success. Thank you.
Thank you so much, ma'am, for your kind words and encouragement. I request Dr. Urmila, madam, to say a few words on behalf of Women in Nephrology Indian Wing. I hope Urmila, madam, is on.
Yeah. Good evening, respected senior colleagues, Dr. Namalwar, Dr. Soundarajan sir, Kalaivani, and dear colleagues. It's really a pleasure to be part of this inaugurating second series of the webinars by IPNA, and I congratulate Kalaivani and Mehta and her team in Mehta Children's Hospital for this wonderful program, and I wish this program the very best. I have missed the earlier ones, and I wish to attend them, the tubular disease symposium, and as Dr. Chandarajan sir says, please get them in a printed form so that we can learn more and we can circulate into our students. The objective of Women in Nephrology is to encourage these kind of educational initiatives where newer speakers, young speakers, and women speakers get a platform to present their knowledge and their data. And I am really grateful to Dr. Kalaivani for taking this initiative. I wish her all the best. Thank you very much.
Thank you, ma'am. May I request Dr. Gauri Shankar sir to introduce the speaker, Dr. Thangavelu sir?
Yes, thank you, ma'am. Can we have Thangavelu sir's CV on projection, ma'am?
Kalaivani, before that, can we request IAP Secretary and President to?
Yes, sir. Sure, sir.
A few words. Ramesh Babu and Dr. Rajendran.
Yeah, Dr. Ramesh is there? Dr. Ramesh? Okay. Ramesh Babu and Treasurer Dr. Gopal Subramaniam and our dear sir, Dr. Thangavelu sir, under his leadership and Mehta Hospital is really doing very well, and this should be a successful one. And all the best for this future endeavor. Thank you much. Thank you.
Good afternoon, sir. Greetings from IAP Chennai City branch. Proud to associate with Mehta's nephrology department and the Department of Pediatrics. It also happens to be the hospital which I'm attached to. Proud to be involved with mentors like Dr. B.R. Namalwar and late Dr. M. Vijay Kumar. I'm not surprised that such extensive academic webinars are being conducted. All the best and waiting to enjoy the academic fest.
Thank you so much, ma'am. I think before moving on to the scientific session, we'll just deliver the vote of thanks and finish off the inauguration, and then we'll have time to have the scientific program in detail. I deem it a great honor and privilege to propose a vote of thanks on this memorable occasion. Let me first start giving the glory to the Almighty God for making this occasion a resounding success, which is evident by the number of registered participants. First, I really thank the International Pediatric Nephrology Association for funding the webinar series. And I thank our Indian Society of Pediatric Nephrology and the Indian Academy of Pediatrics for acting as a guiding force in all the academic programs. And taking the success story of 2020 and 2021 series, which was first of its kind and has acted as an inspiration to sketch out this year academic scientific program into core nephrology, a pediatric tubular disease symposium. This is our third consecutive year, and this series is focused on all practical aspects of tubular disease and will be delivered by experts covering from basics to the updated version. And Dr. Mehta's Hospital, being one of the best teaching institute in all academic activities, it has always been a great support. And I sincerely thank our chairman, Dr. Dilip Mehta, our vice chairman, Dr. Samir Mehta, our director, Dr. Pranav Mehta, Dr. Kannan, our group medical director, Dr. Edwin Fernando, our senior nephrologist, Dr. Saravana Kumar, unit head, to have made this event very much possible and successful. I'm grateful to all our senior pediatricians, Dr. R. Shanmugasundaram, Dr. L. Subramaniam, Dr. Nedinjalian, Dr. Annamalai Vijayaraghavan, Dr. Sarla Rajaji, Dr. Elilarasi, Dr. Prem Kumar for supporting us. And we should, I'm very blessed, and making a dream come true cannot just be achieved by blessings alone, but it requires a lot of moral support and a guiding force. And such support and guidance can only be rendered only by a man with goals. And in that way, I am very much thankful to Dr. Nammalva sir, Dr. Thangavelu sir, and late Dr. M. Vijay Kumar sir. And my special thanks to Dr. Gauri Shankar sir, Head of Department of Pediatrics, and Dr. Srinivasan sir, who have always been my support in reaching my goals. I extend my thanks to my own colleagues, Dr. Sudha, Dr. Sukanya, and our fellows, Dr. Pooja, Sunil, and Arpita. I also thank our branding team, our IT team, and medical social worker of Mehta Hospital. Last but not the least, I thank all my family members and my kids who have always been my pillar of support. And the main thing is the strength of any academic program is having the best of faculty. And we are proud to have them all together for you to share their knowledge. My real thanks to all national and international faculties for their contribution. I always realized that children can fall sick quickly, but with good care, they can recover fast and completely. And I'm sure from a post-event, I think we will be able to handle these kids in a very much better way. All talks in our series are clinically oriented and clinically oriented discussions which will actually enable us to manage children in a better way in our day-to-day practice. So without wasting much time, let's move on to the scientific program to hear from our expert, Dr. S. Thangavelu, who will be delivering a talk on sodium homeostasis, balancing the tilt. And he requires no introduction. Dr. S. Thangavelu has mastered this field of sodium, and he is best at what he does. And let's stay glued to hear from him. So may I request Dr. Gauri from you?
I'll just take over from you.
Yes, sir.
Thanks, Kalevani, for giving me this opportunity. And Dr. S. Thangavelu, he needs no introduction. He's a teacher par excellence. He's the Director, Pediatric Department, Mehta Children's Hospital. He has been a former Assistant Professor of Intensive Care Unit of the Pediatrics at Institute of Child Health and Hospital for Children, Madras Medical College. He had more than 15 years of rural service. He started the Childhood Diabetes Clinic in Children's Hospital, Egmore, and to his credit, now it has crossed more than 700 children. And he has been at the helm of the affairs in pediatric intensive care in Children's Hospital for more than 13 years. He's a PALS instructor from 2004. He has contributed many chapters in books. He has published journal articles. He has received the Best Teacher Award from the Tamil Nadu Dr. MGR Medical University. He has been awarded the Best Doctor Award by Ekam Foundation, Chennai. And he has been conferred the Eminent Doctor Award by Tamil Nadu Medical Council in 2015. He has been awarded the Best Teacher Award by Apollo Hospital in 2016. He has been awarded the Distinguished NB Alumni by ANBA in 2015. He had delivered the Iron Order Oration in 2016 in IAP State Pedicon in Tamil Nadu. He delivered the Professor L.S. Oration during IAP State Branch Pediatric Pulmonology Chapter in 2018. He delivered the Professor BRN Oration in 2021, Professor Sohn's Oration in February 2022. His teaching experience is vast, more than 25 years, and now is the Editor-in-Chief, Indian Journal of Practical Pediatrics. And I am honored to introduce Dr. Amrish Jain. He is the Medical Director, Pediatric Kidney Transplant Program, Children's Hospital of Michigan, USA. He has been awarded Teacher of the Year Award, Associate Professor by the Children's Hospital, Michigan Pediatric Residents. He has been nominated for Excellence in Teaching in Pediatrics Award by colleagues for exemplary teaching in CMU College of Medicine. And he's received the Top Nephrologist Award and Best Peer Review among the physicians honoring the adult and pediatric nephrology in metropolitan Detroit. My warm welcome to both of you, and we'll be happy to hear from you. Over to you, Dr. Thangavelu, sir.
Thank you, Dr. Gaurshankar. Kalaivani, can you stop share so that I can share my presentation?
Yes, I'll stop. Hope you will be able to share now, sir.
Still, your screen is not, you have to stop share. Thank you, Kalaivani. Respected teachers, dear colleagues and friends, I'm very happy, and I'd like to thank Professor B.R. Nammalwar and Dr. Kalaivani for giving me this opportunity for the first talk for a general pediatrician. I'm very thankful to both of you. I begin this talk offering my respects to our mentors, Professor B.R. Nammalwar and Professor M. Vijay Kumar. Next 40 minutes, we are going to discuss about the sodium homeostasis and how we can deal with the hyponatremia. The scope of the discussion has got two parts. First is physiology of sodium homeostasis, which includes the following questions. What is the importance of sodium? How it is distributed? Intake and excretion of sodium, how it is regulated, volume regulation and osmolality regulation. There are conflicts, what the body homeostasis will do. If homeostasis is disturbed, how these problems manifest. Part 2 is dealing with hyponatremia. I just want to ask all the viewers, are you afraid of sodium? Naturally, and people are little afraid to listen to lectures on electrolytes, particularly sodium. But I'm sure you need not feel afraid about it, because all around we are surrounded by sodium. 1,000 kilometers of South Indian coast is full of uppalams and salt fields. You go into the kitchen, you see salt and water there. You go into the history, we fought a war against British Empire by Mahatma Gandhi in the form of salt satyagraha. So you can never be away from salt. So why sodium is considered an important electrolyte? Because it's a dominant cation. It maintains ECF volume and osmolality, and thereby it preserves the cell volume of billion cells in the body. That cell include also human brain. If the ECF volume and osmolality disturbed, the brain either shrinks or enlarges in size. Both leads to very serious critical illness. That is how sodium is got a very important place in the body. How much everybody takes sodium every day? It is based on the culture. Infants receive sodium from breast milk in the form of 7 milliequivalent, and from formula they receive 7 to 13. An average Indian consumes around 11 grams of salt per day. Sodium intake is now recommended not to exceed 2500 milligram, but still we take 4 times of that. Very high sodium intakes because of junk food or fast food, and most of our food contains a lot of sodium. This is a live picture taken from the International Space Station where you see 2/3 of the Earth is made up of water. Of course, the body resembles a mother Earth. 2/3 of the body is made up of water. So total body water is 0.6 into body weight. 2/3 of is intracellular volume. 1/3 is extracellular fluid. Among this 1/3, 3/4 is constituted by ECF, and only 1/4 is plasma volume, which is about 0.05 into the body. This is how the water is distributed. We'll see how the sodium is distributed. Sodium is distributed in different structures, 50% the bone, but we are more concerned and we are going to focus only on the 40% of the sodium in the body, which is concentrated in the ECF. So we'll see how the regulation of sodium happens. Serum sodium is decided by water balance, not by sodium balance, because these are only unique electrolytes where sodium balance is not decided by itself. The power is given to water. Changes in sodium concentration in ECF are associated with disorders of water balance. The key factor, serum sodium is expressed in relation to volume of ECF water as so many milliequivalent per liter, 135 to 140 milliequivalent per liter, related to the water volume, not an absolute number. This is a very, very important key point we should understand. Manipulating the ECF water volume will decrease or increase the serum sodium. So, water, that is the ECF osmolarity, and sodium balance are studied collectively and never individually. If serum sodium is falling, that means water is in excess. So, effort is taken to excrete ECF water. Serum sodium is rising, the effort is taken to conserve ECF water. That is how the sodium is managed. How the regulation of water balance occurs. Adequate ECF sodium is necessary for maintenance of intracellular volume. So both are interconnected. The kidney regulates sodium balance by altering the excretion of sodium. And all of us, we have seen in the previous slide that the intake is highly variable, depending on the diet that the culture dictate to us. So the kidney has a key to control sodium balance by altering the excretion of the sodium content. Urinary sodium excretion is regulated by volume status of the child. For example, if there is a low volume status, kidney conserves sodium. If there is increased volume status, kidney tries to excrete by renin-angiotensin system and vice versa. These are all the factors which regulate sodium and water together. Thirst, AVP, kidney, which is also supported by renin-angiotensin aldosterone mechanisms. Water balance is reflected in osmolarity, which is sensed and maintained in the range of 1 to 2%. It's very, very surprising. It's a tight control. If there is only 1% change in tonicity, immediately body physiological mechanisms comes and saturate that. If it control this to a temperature, my normal temperature is 37 degree. If the temperature changes to 36.7 or 37.3, immediately body homeostasis comes into picture and tightly control it. So much importance is given for osmolarity by the physiology. Disorder of water balance manifests as hypo or hypernatremia. Looking into this, the physiology is a very surprising part. Is all these are controlled by a very, very small organ called the hypothalamus, which is weighing only 4 grams, comparable to the weight of the 1 rupee coin. So that much a powerful organ. In elevated serum osmolarity, osmolarity is the amount of osmotically active particles in the litter. Elevated serum osmolarity should be matched by an appropriately elevated urine osmolarity. Similarly, decrease in serum osmolarity should be matched by decrease in the serum osmolarity. This is a physiological mechanism and axis which determines that. Any stimulus goes out of this physiological axis, whether it's medication or nausea or vomiting, stress, which directly stimulates the hypothalamus for AVP release, could interfere with these delicate physiological mechanisms, and that results in the popular syndrome called the syndrome of inappropriate ejaculation, because it goes away from the physiological axis. Sodium issues are managed by water. How? Sodium is typically like an Indian male. He always depends on other female member in the family, right from a childhood, married man or old man. Always depend on the female member of the family. The serum sodium is falling down in hyponatremia, osmolality also falls down. It means there is excess water in ECF. This stimulates directly the ADH. ADH is switched off. More water is exceeded by the kidney. So water is let out and the serum sodium becomes normal. The issue is rectified. On the other hand, if the serum sodium is increasing, causing hypernatremia, ADH secretion is stimulated, more water is retained, supplemented by a powerful thirst. Both add water and then it dilutes the sodium. The issue is rectified now. This is how the sodium issues are managed by water. That is, sodium and water are thick, close friends like Nanbenda. Those who are outside India, looking, this is a very popular movie in which it explains the friendship between two top stars. Sodium and water maintains that such an amount of friendship among themselves. They don't function independently. They function always together. They depend on each other. Okay. When there is a conflict between ECF volume and osmolarity, I'll just explain. A child with hyponatremia has low osmolarity. So even there is in the presence of low osmolarity, what will happen is it will switch off the ADF. But there is hypovolemic shock. The child has got hyponatremia and hypovolemic shock. The low osmolarity will switch off the ADH, but hypovolemic shock will stimulate the secretion of ADH. So what will happen in this conflict? How the homeostasis will act? This is a very interesting situation. Something like a mother caught between a crying child and a shouting husband. Naturally, she will prefer to go only to a crying baby. So whenever there's a conflicting signal like this, effective volume management becomes a priority, and the volume stimulus outweighs the inhibitory stimulus of hypoosmolarity, and ADH continues to be released. One fundamental rules of medicine is that volume always rules the roost. So whenever there is a volume is affected, volume is given the priority. He talked about whenever there is increasing osmolarity, two protective forces comes for help. One is the ADH, another is the thirst mechanisms. So which comes first? It's very interesting. Physiology, looking at it, is very, very interesting, like a fiction or a story. Osmolarity comes at 275, the ADH is released. 280, thirst mechanisms comes into play. All these physiological mechanisms can be compared to the anecdotal day-to-day life. A person is carrying two parts, one part is leaking. So which should be done first? Either sealing the leak or pouring the water. Naturally, all of us will say that sealing the leak is a priority. Who will seal the leak? Except ADH, will close the collecting ducts so that ADH comes for help first, followed with thirst. When the thirst pour more water, it should not leak. So ADH first seals the leak and thirst add water, and then the osmolarity is controlled. Such an interesting thing happens in the physiology. Next is, why we talk so much about the serum sodium, how it is important. Serum sodium maintains the ECF osmolarity. Imagine, I am just telling three situations. This is cell, osmolarity is about 280 by 295. You put in a fluid containing similar osmolarity of 280 by 295. There is no osmolar variation, so that there is no water shift across the cell membrane. Situation 2, I put this into a hypertonic solution with a high osmolarity. What will happen is the water moves, because water moves from the hypotonic to hypertonic environment. Water moves out from the cell into the extracellular fluid so that the cell shrinks. We move to third situation. The cell is put into a hypotonic fluid where the water movement occurs in the reverse direction. It goes into the cell and cell starts swelling. Imagine a round mango pickle. Mango is put into the salty water so that the pickle is formed. So the mango shrinks to form the pickle. That is what happened in hypernatremia. The brain shrinks and all the penetrating vessels got distorted and resulting in intracranial bleed. Similarly, we are all fond of food. That's why I'm just giving a comparison for the food. The hard, small rice is put into a small amount of salt in the water and boil. The water moves into the rice and the rice puffed up to become a eatable, edible rice. That is how the brain in the hyponatremia swells up to cause cerebral edema. So in hyponatremia, brain swells up to cause cerebral edema. In hypernatremia, it shrinks to cause intracranial bleeding. There are a lot of made for each other couples in our milieu interior or the human physiology, like calcium and phosphates, ventilation, oxygenation, like that. Sodium and water are the supreme parents or supreme couple which sustain the dynamic role. When they maintain the osmotic balance among the three body spaces, effective circulatory volume, preservation of cell size, including brain cells. So, physiology says that we can't separate these two parents. Problems of both sodium and water have to be studied, analyzed, and resolved together only and not alone. With this, we'll move on to how we are going to recognize and deal with hyponatremia. What are the clinical symptoms of hyponatremia? All along we are discussing all the symptom disturbances in sodium, serum sodium level causing hypo or hypernatremia will definitely affect the brain, either in the form of cerebral edema, shrinking and leading to intracranial hemorrhage and thrombosis. No doubt that in the sodium disturbances, the symptoms, manifesting symptoms are predominantly neurological. Lesson 135, apathy, anorexia, nausea, vomiting, lethargy, non-specific symptoms. It goes very severe, like less than 120 milligram per liter, cause muscular twitching, headache, seizures, irregular respiration, abnormal sensorium. The severity of neurological symptoms depend not only on the magnitude of the serum sodium levels and how rapidly they develop. So, in acute severe hyponatremia, symptom will be more predominant than the chronic severe hyponatremia. So, hyponatremia leads to cerebral edema and hypernatremia leads to shrinking of the brain. Hyponatremia is categorized into three parts or three types based on the volume, space. There is a hypovolemia associated with hyponatremia, or isovolemia with hyponatremia, or hypervolimia with hyponatremia. If there is a volume loss as well as sodium loss, hypovolemia hyponatremia causes are either a renal loss or an extrarenal loss. Extrarenal loss, here what happens is there is both are lost, both water and sodium are lost, but more sodium is lost than the water. So resulting in hypovolemic hyponatremia. So what are the extrarenal losses? Vomiting, diarrhea, third spacing is the commonest one, like dengue or intestinal obstruction, peritonitis, pancreatitis. All these third spacing lead to extrarenal losses. In the extrarenal loss, urine sodium will be lesser than 20 millimole because kidney wants to conserve sodium. On the other hand, in the renal loss, urine sodium will be more than 20 because that is the reason for the hyponatremia, which happens in renal tubular cirrhosis, cerebral salt wasting syndrome, diabetic ketosis, diuretic therapy, adrenal insufficiency, pseudohypoaldosteronism. This is the most common cause of hyponatremia. Next comes the Eulemic hyponatremia. Here, there is no sodium loss, a slight marginal excess of water resulting in hyponatremia. Eulemic hyponatremia. Common causes are water intoxication, use of 5% dextrose in the postoperative period, or psychogenic water drinking, tape water enema, or syndrome of inappropriate ADH secretion. Third category is hypervolemic hyponatremia, where both are in excess, water and sodium both are in excess, but water more than the sodium excess. Causes are renal failure, nephrotic syndrome, congestive heart failure, protein energy malnutrition, cirrhosis liver. The beauty of this categorization is just looking at the child, we can make a diagnosis. We can't compare this to a clinic, the laboratory assessment. The child looks dehydrated and hyponatremia is hypovolemic. A child looks edematous means hypervolemic hyponatremia. No edema, no dehydration means it is eulemic hyponatremia. I'm just proposing a 5-step evaluation for hyponatremia. First question is there any neurological symptom? We see a child with sodium less than 135 or hyponatremia. First question asked is any neurological symptoms. Second question is it true hyponatremia or a pseudohyponatremia? What is the volume status? Is it an acute onset or a chronic onset? Here, unlike in fever and other diseases, here acute means anything less than 48 hours. The illness is acute hyponatremia. More than 48 hours itself is considered chronic in fluid electrolyte disturbances. Last one is urine sodium levels. We'll just see the first case. It's a child with common condition, diarrhea, dehydration. 1-year-old boy admitted for diarrhea. Last voided in about 8 hours ago. Skin turgor retained, but tongue is dry and AF depressed. Mild dehydration. There is tachycardia. BP maintained. Is conscious, drinking water avidly. Sodium is 123. So what do you see here is hyponatremic dehydration or hypovolemic hyponatremia. Both are same only, the priority is changing. So what is your approach to this patient? What we are going to do that? I'm just offering this small, based on the 5 steps. This is a simple algorithm. Serum sodium 135. My first question is, if the child has got symptoms, symptom means a neurological symptom, because if the child has got neurological symptom, convulsion is an urgency. We don't have time even to analyze and think. If the child has got neurological system like convulsions or unconsciousness, assess and support the ABCs as the first one. Then give 20 ml per kg of normal saline over 1 hour, 30 minutes to 1 hour, which will saturate the hyponatremia by raising at least by 5 millimole above the basal level, so that this will tide over the crisis and save the child from convulsions or alters in sodium. If there is no neurological symptoms, then you think whether it is a pseudohyponatremia or true hyponatremia. True and pseudo, if you are in a tertiary care center, you can do osmolality and then decide if the usually hyponatremia associates with true hyponatremia associates with hypoosmolarity. If the hypoosmolarity is true hyponatremia, if it is hyper or isoosmolarity, it is a pseudohyponatremia. And if the child is asymptomatic and true hyponatremia, next question comes is whether is a hypovolemic, isovolemic, or hypervolemic. And fourth question is what is whether it is acute or chronic. So we will study how we are going to manage hypovolemic, normovolemic, and hypervolemic hyponatremia. In hypovolemic hyponatremia, simple logic is you have to add more water and sodium because both are lost. So generally we give normal saline or pregnant lactate boluses. Dehydration is corrected by deficit correction followed by maintenance. If it is a normovolemic hyponatremia, it's only restrict the water. We don't add anything. In hypervolemic, we restrict both water and sodium. This is the basis for categorizing the hyponatremia into 3 groups. So if we will see this child, we raise this question, see the first case scenario. Any neurological symptom, because this child neurological symptoms are not, the child was conscious, no neurological symptoms. And second is a true or pseudo hyponatremia. Sample is appropriate. Blood glucose is 96 milligram. Sample is not lipemic, so it is a true hyponatremia. So what is the volume state? The child is dehydrated, so it is a hypovolemic hyponatremia. It's an acute or chronic, it's acute diarrhea, so it's acute. Urine sodium was not done. This is a simple child acute diarrhea. So our conclusion is, our inference is acute diarrhea because of GI loss of water and sodium, moderate dehydration, hypovolemic hyponatremia. How we are going to treat this child? This, all of us know the basics. Mild dehydration means 30 to 40 ml per kg. Moderate means 50 to 70 ml per kg. Severe means 100 ml per kg. This is amount lost and this is amount to be replaced. So earlier, before 2007, we used to calculate water and sodium separately. Water means for maintenance, a 10 kg child needs 1000 ml, but deficit needs 50 ml into 10 kg, so 500 ml. And total is 1500 ml of water to be given over a period of 24 to 36 hours. That's what the calculation. For sodium, if we take, serum sodium is 123. We used to calculate this way earlier. 10 into 0.6 into a deficit, it comes to around 72 millimole of sodium. So child may need 30 millimole, 30 milliequivalent for maintenance, 72 milliequivalent for deficit correction, all put together 102. Child may be treated with the half normal saline or little more than that. That is the calculation we used to do it earlier, before 2007. Here, correction of sodium and water should be done together and not separately. Why? At 2000, National Patient Safety Agency was issued of National NHS, UKS issued a patient safety alert, said that we have to change our pattern of using IV fluids. Before taking that order, we will see how the IV fluids are used. First is resuscitation. Resuscitation always use isotonic fluid. But in deficit correction or dehydration correction, as well as maintenance, we used to give only hypotonic solutions. So patient safety alert of NHS Trust issued an order that isolate P should be removed from all the hospital cupboards. It should be replaced by isotonic fluid. They advise that even for deficit correction, we have to use only isotonic fluid like normal saline or ringer lactate. And maintenance generally we used to give isolate P. That should be removed and should be replaced by isotonic fluid. That was the advice given by NHS in 2007. After that, the management is changed. Here we calculate the deficit. 500 plus 1000, 1500 ml is a deficit. This 1500 ml, we don't calculate sodium separately. This 1500 ml is given as isotonic fluid like normal saline or glucose normal saline. Half of the fluid is given in the first 8 hours, that is 750 ml. Next 750 ml given over 16 hours. So by 24 hours, we are able to infuse the whole fluid without calculating sodium separately. Just correct only the dehydration by calculating the volume loss only, but replace only with the isotonic fluid. The clinically monitor, repeat electrolysis can be done after 24 hours. If any new symptoms, repeat sodium at that point, we can check the sodium and then decide. Coming back to the case scenario, the child continues to have oral feeds. IV fluid stopped after 24 hours, got discharged after 48 hours. Here, I just want to raise one question. Why we changed from half normal saline to normal saline in the deficit correction is, what is the reason for hyponatremia in a child with diarrhea? Because sodium loss is maximum sodium loss even in cholera is only 90. So the hyponatremia is not due to the sodium loss in the stools. It is an indirect response of the ADH. Whenever there is dehydration hypovolemia, ADH is called for help. ADH retains more free water and that dilutes the sodium to cause hyponatremia. So how do you correct hyponatremia? Unless you ask the ADH to go back, unless you switch off the ADH, we can never correct hyponatremia. That is why we give a volume bolus, isotonic volume bolus, so that the once hypovolemia is corrected, automatically ADH is stopped secreting and then sodium is corrected. Okay, this is the step of management in a child doesn't have any neurological symptoms. So the child has got a neurological symptom. How do we manage? The child comes with convulsions, even if it is 110 or 105, the target is to increase the serum sodium only by 5 milliequivalent. From 110 means up to 115. If it is 105 means up to 110. Which fluid is ideal fluid? Earlier we used to give 3% saline for crisis management, 5 ml per kg of 3% saline, or normal saline 20 ml per kg. If we calculate, both will give somewhere around 25 to 30 milliequivalent of sodium is replaced by both is fluid, 3% saline at normal saline 20 ml per kg. What do you think which is ideal fluid? Ideal fluid here is a normal saline because it corrects hypovolemia. Normal saline corrects hypovolemia. At the same time, it also gives sodium replacement. But on the other hand, 3% saline cannot replace the volume correction because the volume given is very small. It can only replace the sodium. So 3% saline is not a right choice in hypovolemia hyponatremia in the crisis management. Only normal saline is the right way of managing the crisis during the child who is symptomatic, neurologically symptomatic. We'll move on to the second case scenario. This is a 1-year-old girl, diarrheal dehydration, improved after dehydration. Child was getting D5 half normal saline with the potassium 20 milliequivalent per liter for 48 hours and now stopped 2 hours ago. On the third day, because of the when there is mild hyponatremia, electrolytes were repeated. To our surprise, electrolytes were very bad compared to the child is improved, but electrolytes were bad. Serum sodium was 100 millimole. Before treatment it was 131. Serum potassium was 3 before treatment. After treatment is 7 millimole. But looking at the child is conscious, well perfused, voiding urine normally, no dehydration. So here you have a paradoxical situation where the lab tells something different, but clinically child looks different. Child looks well, but lab give a very, very wrong directions. So when you come across this situation, you think of pseudohyponatremia. So we'll ask the 5 questions to the same case scenario. Any neurological symptoms? No. True or pseudo? It's more likely to be pseudo because there are no clinical correlations. Pseudo is very, very highly likely. It's acute diarrhea, so it's acute situation. Volume status is normal. Urine sodium was not done. So how it happened is the child was receiving fluid through IV line started at dorsum of the hand, half normal saline and isolate P, potassium 20, half normal saline with 20 milligram potassium. When you collect a sample at this point, at the elbow, at the red arrow point, naturally the same fluid will dilute the blood and you'll get a wrong value. That's what happened in this child. So whenever the lab results are not correlating, think about pseudohyponatremia. In this situation, ask the nurse, ask her, where is the sample collection? She will tell that yes, the same hand we collected in the elbow, which is highly likely to cause pseudohyponatremia. You also ask the nurse to check the glucose because the hyperglycemia is one reason for pseudohyponatremia. We can call the lab technician, the lab to see whether can you tell the color of the sample. If the color is lipemic, is another reason for pseudohyponatremia. Last one is hyperprotemia is also a very rare cause of pseudohyponatremia. Here the God is kind towards us. Hyperprotemia is a very, very rare condition seen in pediatrics. So to put together, pseudohyponatremia situation where the serum sodium is normal, but because of various other factors, it is given as the serum sodium level is lower. One reason is improper sampling, that is proximal to the sample, proximal to the IV side, we have collect the samples. Or if it present with high osmolarity, hyperglycemia and Mandela therapy also can cause pseudohyponatremia. Third one is, if there is a normal osmolarity, consider the possibility of hyperlipidemia and hyperproteinemia. So if the lab person says that sample you sent showing lipemic serum. That means lipemic serum is the reason for causing hyponatremia. So pseudohyponatremia will be suspected. Normally in a true hyponatremia, osmolality is lowered. If the osmolality is high, you suspect hyperglycemia and mannitol therapy. If the osmolality is normal, think of hyperlipidemia. But osmolality, serum osmolality checking may not be available in every center. So by asking the nurse and asking the lab technician, looking at the samples, we can reasonably come to a conclusion to make a diagnosis of pseudohyponatremia. Third case is a child with diabetic ketosis. The child diabetic ketosis comes to us. Initial sodium is 125. There is a formula to calculate actual sodium is, for every 100 milligram above the normal, you add 1.6. Here it is 800. So 7 into 1.6 is 11.2. Actual sodium is 125 plus 11.2 is 136.2. This is not hyponatremia, but here it looks like a very serious hyponatremia. How this happens? Because of hypertonicity outside, the water comes out to dilute the glucose, and in fact, it dilutes the sodium. It's a translocation of water to the ECF causing fall in the sodium. So this is should not be taken as a true hyponatremia. This is one of the common thing happens in diabetic ketosis. You can see that from 8 and another 12 hours, gradually glucose is coming down. The sodium is also increasing. Now from 125 to increase to 142 without any specific management to raise the serum sodium. This is another cause for pseudohyponatremia. So we'll apply the 5-step evaluation here in this case scenario. Any neurological symptoms? No. True or pseudo? More likely to be pseudo because sample is appropriate, but the glucose is higher. So it can lead to hyperosmolarity and pseudohyponatremia. Volume status, mild dehydration, acute or chronic, acute. So urine sodium is not done. So this is a child with pseudohyponatremia because of hyperglycemia, which does not need any specific management, which will get corrected once we correct the diabetic ketosis state. This is a child, 5-year-old boy with meningitis. On third day of the hospital stay, I expect the child to improve, but unfortunately, his disease is worse and he develops seizures. So a child who is expected to improve, developing seizures and worsening, I think of 3 possibilities. One is probably child who develops some vascular pathology like infarction or bleed, or a worsening meningitis. Probably my diagnosis is not correct, or my microbe is, what the antibiotic choice is not correct. So child is worsening meningitis. Or third possibility is hyponatremia. Here the repeat brain CT after stabilization, repeat CT was done, which was same. So that exclude the first etiology. No infarction, no bleed. CSF analysis was done, which shows that improving meningitis. So that also exclude 2. Now the serum sodium here is 118. So this is the reason for worsening of the child. The child with meningitis or tumor or neurosurgical procedures develop neurological manifestation with hyponatremia. There are only 3 causes. One is probably somebody is inappropriately using hypotonic solution. Ideal maintenance fluid for a child with neurological problem, meningitis or neurosurgery or tumor is isotonic fluid like normal saline. Somebody is using half normal saline, that can drop the sodium. But here the child is getting GNS, so that is not the reason. Second possibility is SIADH. SIADH, usually child will have oliguria, no dehydration, no edema. Cerebral salt wasting, child will be dehydrated and polyuria. We look at this case now. Child is a normal saline. His urine output is 4.8 ml per kg per almost polyuric. And child also dehydrated. Urine sodium is 190 millimole per liter. All this favor a diagnosis of cerebral salt wasting syndrome. So stepwise analysis brought the diagnosis of this hyponatremia as true hyponatremia because of cerebral salt wasting syndrome. Any neurological symptoms? Yes, child has got neurological symptoms, primary as well as secondary neurological symptoms. True or pseudo? Sample is appropriate, glucose is normal, sample not lipemic, so it is not pseudo, it is true. Volume status mild dehydration, so hypovolimia. Acute or chronic, acute. Urine sodium gives a clue as 190 milliequal per liter. So we are dealing with a child with hypovolemic hyponatremia because of urinary losses, because of high urine sodium, symptomatic child. So this is a child with cerebral salt wasting syndrome leading to hypovolemic hyponatremia. So what are these are the 2 important causes of a child with neurological problem with hyponatremia. We'll see the differences. SIADH, the weight is increased. In cerebral salt wasting, weight will be decreased because of dehydration. In SIADH, there won't be any dehydration edema, but in cerebral salt wasting, there will be dehydration. Urine output low in SIADH, serum uric acid is low, but in cerebral salt wasting syndrome, urine output is large, uric acid is normal. Urine sodium will clearly differentiate. In SADH will be between 20 to 40 millimole per liter. Here it will be more than 150 millimole per liter. Because we have to clearly differentiate SADH and cerebral salt wasting because it's completely two different directions, north and south. Here in SADH, we have to restrict the intake of fluid to 2/3 maintenance. But in cerebral salt wasting, you have to replace like something like a diarrhea dehydration. We have to do deficit correction. We have to replace more sodium and water. So differentiating between SADH and cerebral salt wasting very, very much important to make a correct decision. So his urine output of 4.8 ml per kg per hour, urine sodium 190. We made a diagnosis of cerebral salt wasting syndrome, managed with 3% saline. With supportive management, child completely recovered. We move on to the case scenario 5. This is an 18-month-old child admitted for pneumonia on 24th. Because of worsening, the child was shifted to ICU. Child didn't have seizures, more distressed and slightly drowsy. On admission, PICU, serum sodium fallen from 132 to 128. Others are almost normal. Child was put on nasopharyngeal CPAP. There is no shock. So what has happened here? Child with pneumonia, serum sodium is dropping after admission. What is the reason? Is there any neurological symptoms? No neurological symptom. Is it a true or pseudohyponatremia? Sample is appropriate, glucose normal, sample not lipemic. So it is a true hyponatremia only. But one thing is very strikingly different is here the serum osmolarity is 258. We saw in the previous slides, serum and urine osmolarity move in same direction. When the serum osmolarity is lower from 290 to 258, urine osmolarity also should go down from 290 to lower down. This is according to the physiological axis. But here what happened is surprisingly urine osmolarity is more than serum osmolarity. This happens only when hypothalamus is stimulated for secretion of ADH through a direct stimulation without going through the physiological axis. Child also had hypovolemia. So now we are dealing with the child with Eulemic Hyponatremia, asymptomatic child, urine osmolarity more than serum osmolarity. It's a classical picture we see in syndrome of inappropriate ADH secretion in child with pneumonia. This will very closely resemble Addison thyroid hypothyroidism. This has to be excluded before confirming the diagnosis of SADH. What are all situations you will encounter SADH? Syndrome of inappropriate ADH secretion. Common situation is hospitalization, pain, anxiety, vomiting, surgery. These are all non-osmotic stimulus. So most of the hormones like insulin, growth hormone, or cortisol, unless they are abnormally low or high, they behave like a hero. But the ADH is sometimes behave like a hero, sometimes behave like a villain. So here it responds to non-osmotic stimulus like pain, anxiety, vomiting, surgery. This comes into the blood and causes a lot of problems by SADH. Common disorders that lead to SADH are respiratory problem like pneumonia, bronchiolitis, sinus problem like infection, surgery, trauma. Some drugs like opiate, ventilation, surgery, and anesthetic medication also lead to SADH. Now, what is syndrome of inappropriate ADH? Before asking that question, what is appropriate? There are only two appropriate stimuli for ADH, either low volume or increasing osmolarity. You just see here, the osmolarity is 310, ADH is secreted, yes. 300, yes, ADH is secreted. 290 osmolarity, yes, secreted. 280, ADH is secreted. When it comes down to 275, when the osmolarity is fallen down to very low level, automatically ADH stops secreting. That is the appropriate stimulation. We'll see what is inappropriate. Look at here. Here, when you go down, yes, 275, the appropriate stimulation should stop. The ADH should stop. But here, unfortunately, ADH continues to secrete despite falling osmolarity. This is called the syndrome of inappropriate ADH secretions. So what are the criteria to make diagnosis SADH? Hyponatremia less than 135. Plasma osmolarity is lower, but urine osmolarity is more than plasma osmolarity in contrast to the control of physiological axis. Urine sodium may be somewhere between 20 to 50 millimoles. No edema, no dehydration, normal major organ functions, no diuretic use. This is the criteria to make the diagnosis of SADH. We learn now what is appropriate ADH secretion. We also learned what is inappropriate ADH secretion. So this is the osmotic stimulus is increasing osmolarity, volume stimulus hypovolemia. In the absence of this, SADH happens when there is a non-osmotic, non-volume stimulus in the form of stress of hospitalization, pain, vomiting, dehydration, fever. So all these children who are hospitalized likely to develop ascites because of the non-osmotic stimulus, which causes expansion of the intravascular volume, creates a hospital-acquired hyponatremia that leads to various complications. Sometimes you need not ask so many questions. Even in the first sight itself, we can identify the etiology, like this case scenario. This is a child who underwent fundal plication gastrostomy. It's a child with cerebral palsy, seizure disorder. 4 hours after surgery, child's serum routine electrolyte estimation showed a very low sodium, 126. Pre-op sodium was 140. What has happened? Fortunately, clinically, child is asymptomatic. The reason is very obvious because child was not. So, first question we should ask in any child hyponatremia, what the maintenance fluid child is getting. Here, unfortunately, child was following an old procedure like giving isolate P. So, it's a hypertonic fluid. So, naturally, that is the reason for hyponatremia. So, nothing much of investigation needed except you change this to an isotonic fluid like D5 normal saline. That itself will correct without doing any other investigation. So, whenever we see serum sodium level less than 140, the maintenance fluid should be isotonic fluid even in a very young infant. Case number 7 is a 1-month-old girl. One sibling died earlier with similar problems. Child is brought with dehydration, but perfusion was adequate. Looking at the picture, probably would have come to the diagnosis. Serum sodium was 129, potassium 5.4, high urea, 17.5 levels are higher. It's a classical presentation of congenital hyperplasia. So whenever you see a child with low sodium, low glucose, high urea and high potassium, the possibility is congenital hyperplasia. Here the diagnosis becomes very obvious if you go methodically. With hydrocortisone replacement and normal saline child can be managed, initial crisis can be overcome before we hand over the child to the endocrinologist. So if you're looking at this, throwing these 5 questions to this case scenario, any neurological symptoms? No. True or pseudo? Clinical conditions favor only true hyponatremia. We don't have any reason to believe pseudo hyponatremia. The acute or chronic is a chronic situation. What is the volume status? Hypovolimia. Where is the loss? Mainly a renal loss. Urine sodium was not done. If done, it will be usually more than 40 milli per liter. We'll come back to this. I just want to reiterate 3 types of hyponatremia: hypovolemic hyponatremia, normvolemic hyponatremia, and hypervolemic hyponatremia. Depending on the presence of dehydration, edema, or no edema, no dehydration. In hypovolemic hyponatremia, we have to replace more water and sodium to correct the deficit and maintenance. In normovolemic, just restrict the water to 2/3 or 50% maintenance. In the hypervolemic hyponatremia, restrict the water as well as sodium and treat the primary cause. Now we come to the management. So how do we manage this? In chronic hyponatremia, there are some diseases where the management itself will lead to serious complications, like for example, like a chemotherapy. A similar situation will happen when we correct hypo as well as hypernatremia. We must be very, very careful in treating hypo and hypernatremia because they can create a lot of problems more than the primary illness itself. Take a situation in chronic hyponatremia, the risk due to rapid correction will lead to osmotic disequilibrium syndrome. If we correct it rapidly within 48 hours, because of physiological adjustment, sodium would have been managed. If we do it very rapidly within 48 hours, it leads to a complication called osmotic disequilibrium syndrome and may cause problems. In a patient with low risk of osmotic disequilibrium syndrome, generally the correction should be, earlier we used to say that 0.5 millicoulomb per hour or 8 to 10 millicoulomb per day only should be corrected. For example, if the serum sodium is 110, we can only raise it to 120 millicoulomb for 24 hours. So only 10 millicoulomb per day, that is the cutoff. Now the cutoff is being reduced now. In a child with a low risk of ODS, you can raise the serum sodium only 4 to 8 millimole per day. There are high risk of osmotic disequilibrium syndrome. We can only raise the serum sodium only with 6 millimole per day. Very slow rise only should be done. Should not exceed more than 8 millimole per day. A slow correction only will prevent complication like central pontine myelinosis, old terminology. New terminology is the osmotic disequilibrium syndrome. What are all the high risk factors for osmotic disequilibrium syndrome? Where you have to correct very slowly. Probably in alcoholism in adolescents, liver disease, malnutrition, severe hypokalemia. In these situations, your rate of correction should be only 4 to 6 millimole per day. So very, very carefully you have to raise the serum sodium. What will happen if we correct it fast? This picture will try to explain this. So this is a normal brain cell. Suddenly serum sodium falls to 120. So we have seen earlier, like a rice put into the low salt water, the water moves from extracellular compartment to intracellular compartment. So brain starts swelling up, cerebral edema. See, the brain cell increases size because of hyponatremia. And then body has given, physiology has given a special power to the brain to reschedule its size of the cells. So it has got its own inherent mechanisms. So what it does is it extrudes the electrolytes. It also creates osmolytes. Osmolytes and electrolytes are expelled out. When it expels out, they also take water. So brain itself has an auto-regulation to reduce the brain size from cerebral edema to a normal size. See, from 2 to 3 to 4. In 48 hours, brain can create osmolytes or exclude the electrolytes outside the cell so that water also follows and cell size reduced by its own auto-regulation mechanism. That happens around 48 hours they take it. So when the body is adjusting itself to reduce the size of brain cells, suddenly you interfere and give 3% saline. That interference will rapidly reduce the size to further, leading to a complication called central pontine myelinosis or osmotic disequilibrium syndrome. So if you want to avoid this paradoxical complication, there are corrections should be done very slowly. So first 48 hours, acute hyponatremia, gradually the body adjusts to maintain the size. If you quickly intervene and reduce the serum sodium levels, it increase serum sodium levels leads to complication like osmotic disequilibrium syndrome. To avoid this, in a chronic hyponatremia, the correction should be done very slowly. In acute hyponatremia, we can do it fastly. So in acute hyponatremia, that is hyponatremia developed over the 48 hours, the risk of cerebral edema is more than central pontine myelinosis. So rapid correction allowed if it is acute hyponatremia within 48 hours. So risk of cerebral edema is more. We have to bring down we increase the serum sodium faster. The risk of cerebral edema is more than central pontine myelinosis. So rapid correction can be done. But in a chronic hyponatremia, lasting for 2 days, 3 days, 4 days, the risk of central pontine myelinosis is more than cerebral edema. Here the slow correction should be done. Here you can do it even up to 8 to 12 millicoulomb per day, you can do it. But here the correction will be only very low, 6 to 8 millicoulomb per day only you have to correct. 6 to 8 millicoulomb per means, what does it mean? Means from 120 you can increase to 126 in one day, then to 132 in the second day. So the management is based on how nicely you balance acute versus chronic and how nicely you balance the risk of cerebral edema to the risk of central pontine myelinosis. This is one of the paper published very early in 1994. Here you see a child has been, correction has been done in chronic cases. A slow correction has been done. Very slow correction. You see here there are 3 colors are there. This is the uncomplicated outcome. Gray one is a transient sequelae. White one is a permanent sequelae. When you do a slow correction, about 10 to 12, less than 12 millimole per day, and slow correction, completely recovered without any complications in a chronic case, chronic hyponatremia. But if you rapidly reduce, what happens here is the good number of children, they develop permanent sequelae and few develop the transient sequelae, only small amount is recovered. But in acute hyponatremia, even if you do it quickly, the complication will never develop. So the lesson we learned from here is in acute hyponatremia, we can correct it very slow, very quickly. But in chronic hyponatremia, the duration of the illness is more than 48 hours. You have to do it, correction should be done very slowly so that we avoid the permanent sequelae caused by central pontine myelinosis or the osmotic disequilibrium. So that's what the lesson we learned from this slide. See, so far, we talked about hyponatremia. We raised 5 questions. First question is it neurological symptoms? Is it neurologically symptomatic, yes or no? Is it true or pseudo? Third is it is volume, what is the volume status, hypovolemic, isovolemic or hyperolymic? Last question is acute or chronic? Sorry, fifth one is, fourth one is acute or chronic. Fifth one is whether it is, what is the urine sodium levels? And then we try to analyze these 5 questions by analyzing some certain case scenarios. We also understood that the correction should be done very slowly in chronic hyponatremia. Chronic means more than 48 hours. In acute hyponatremia, we can do the rapid correction. So we all along these slides, all along this last 30 minutes, we are all talked about numbers. But this is a very interesting picture taken from one of the very early ICU book called Tobin, where you see 5 doctors and paramedicals are there. None of them are looking at the patient. He's looking at the ventilator monitor. He's looking at another monitor. They are looking at the computer. Nobody is looking at the patient. So the lesson is, whenever the numbers are not explained by the clinical condition, what is the next gold standard to confirm or disprove is come back to the child, physical examination of the child. Whenever the numbers are not giving a correct picture, come back to the child to make a decision. So don't make the decision only based on the lab values. Thank you very much for your patient listening.
Thank you so much, sir, for the enlightening talk. It was really crystal clear. And I'm very much justified in giving this topic to you, sir. Thank you so much. We'll take up the question towards the end of the session verbally, sir. There are a few questions, but we'll take it up verbally towards the end of the session. The next speaker is, I take the pleasure of introducing the course director of the event, Dr. Amrish Jain. Dr. Amrish Jain. Dr. Amrish Jain is a medical director, pediatric kidney transplant program at Children's Hospital of Michigan, and he is a recipient of various awards. He has received the Best Teacher Award by Michigan Pediatric Hospital, and he has also received the Top Nephrologist Award by the Detroit Medical Center. Over to Dr. Amrish Jain to deliver his talk on hypernatremia, a case-based approach.
Thank you so much, Kalaivani, and thank you, the organizing committee, for inviting me to give the talk. It has been a pleasure, and it has been such a wonderful last 1 hour, and I'm sure, the next few weeks, it's going to be an academic feast, and I hope, all the attendees are enjoying the talk so far. So again, thank you to the Department of Pediatrics and Pediatric Nephrology at Mehta Hospital, the organizing committee, IPNA, Kalaivani, for our collaboration, and I hope you enjoy the talk. And I can also tell you, Dr. Thiravandru, made my life so easy. He has made it so simple for everybody, and the friendship between the sodium and the water, he has explained it so nicely. I think, we will go through the rest of the talk, it's going to be easy because he has cleared the concept so well. So thank you so much, sir. So I will start with a case scenario since the concepts are already clear. This is a 6-month-old boy who was brought to the emergency department with diarrhea and vomiting for 4 days. He is refusing to drink formula for 1 day. He has no fever, abdominal distension, or blood in the stool. The boy's heart rate is 130 beats per minute, respiratory rate is 18 breaths per minute, and blood pressure is 82/48 millimeters of mercury. He is lethargic, mucous membrane is dry, and his capillary refill time is 3 seconds. His skin has a doughy feel. He has a shrill cry when aroused. The rest of the physical examination findings are normal. The laboratory tests are revealed on the other side. You can see the sodium is 169, potassium is 3.2, chloride at 114, bicarb is 20, blood urea nitrogen is 34, creatinine is 0.4, glucose is 90 milligram per deciliter. The urine which is obtained shows a specific gravity of 1030, and rest of the urine analysis is negative. So coming to the question that we have, you can see of the following, the most appropriate management of this boy's condition is to administer half normal saline bolus, administer intravenous vasopressin, replace the free water deficit, and correct the serum sodium over 24 hours. So having learned about the hyponatremia, my goal will be to go over this question and learn about hypernatremia. So when serum sodium is more than 150 MEQs per liter, we define it as hypernatremia. Although some books, do go down to 145 and above as the cutoff also. As we learned with hyponatremia, what is important is how quickly the sodium changes. So that is where the rapidity comes in. And how acute is it? Is it acute? Is it chronic? Pretty much similar questions that we learned with hyponatremia, we have to answer with hypernatremia also, whether it is acute, whether it's rapid, because that would determine the severity of neurological injury. How common is it? I pulled up some studies, different countries, this is a very multinational, webinar, and I wanted to make sure that I cover data from all different places. So first study by Foreman et al., which was published in 2012, this is a Scottish study, And in their pediatric patients, they found that hypernatremia was in about 0.04%. And this was a tertiary care hospital-based study. In the same study, when they looked at the newborns, it was almost 10-fold higher. It was 0.4%. So newborns, especially in the first 2 weeks, are at very high risk of hypernatremia. Moritz et al., this is a US study from Texas Children's Hospital. And again, a tertiary center, big center, they saw hypernatremia of almost 1.4%. In India, since we know acute gastroenteritis is the most common reason why you would see hypernatremia, I pulled up a study from Dustidar et al., this is from Calcutta. And in that study, we saw that hypernatremia was seen in 6.5% of the acute gastroenteritis patients. 22% in hyponatremia was 22% was hyponatremia, and 71% were isonatremia. So of all 3 dehydration cases, hypernatremia actually is the least common that we see, but still clinically it becomes very important. Now these, again, we have gone through in detail in the last talk, but just to mention that especially in cases of sodium, and when we talk about hypernatremia, plasma osmolality becomes such an important thing. We know that osmotic forces determine the water distribution in the body. When impermeable solutes are present, so as shown in this diagram, that this is a closed compartment, this is a membrane in between, and on this side, we have more solutes, which is in the form of glucose per water. So water is going to move from lower osmolarity to higher osmolarity. And again, as we have learned in hyponatremia, these water shifts become so important clinically because otherwise your patient may have neurological injuries. Now, this concept, as we all know, as a nephrologist, we use in dialysis all the time. When we talk about peritoneal dialysis, we are using different concentration of diarrheal fluids putting in the abdomen, and that is how we determine the fluid shifts. So this concept helps us in different ways. Now, one formula which we would want to go over is how do we calculate plasma osmolality? So it is 2 times the sodium. Check it here, 2 times the sodium. And we know normal serum sodium says about 140. So 140 times 2 is 280. Sodium actually contributes most to the osmolality of the patient. And that is why when we talk about hypernatremia, serum osmolality goes pretty much hand in hand. The other components which are used in osmolality are the glucose and the BUN. The formula being 2 times the sodium plus glucose divided by 18 plus BUN divided by 2.8. Again, this concept is important because if sodium is high, that is hypernatremia is there, plasma osmolality is going to be high. If glucose is high, if we are dealing with diabetic ketoacidosis, plasma osmolality is going to be high. If renal failure is there, if BUN is high, again, the plasma osmolality is going to be high. All these 3 clinical conditions, we have to correct the osmolality slowly, otherwise we will be in trouble. Now coming to what are the causes of hypernatremia? Why does hypernatremia develop? As we have said, that it's a friendship between sodium and water. So pretty much the same thing, hypernatremia results when there is an imbalance in the body's handling of water. So as we said, there is relative excess of effective plasma osmolality. So there could be 2 reasons. So either the water loss is not replaced. So, you're having lots of water losses, and that is how, you lose all the water and it's not being replaced. Your sodium levels go up. Or second condition could be if there is excessive ingestion of salt relative to the water. So you're taking more salt as compared to water, and that you become hypernatremic. Pretty simple concept. Either you lose more water or you take in more salt because they go, together. Now, this gives a lot of information, and it tells us about what are the reasons why somebody would develop hypernatremia? Again, as we said with hyponatremia, that either it could be, water related or sodium related. When we talk about hypernatremia, one is water depletion. That means the total body water has reduced much more than the solute depletion. Both have gone down. We talked about, diarrhea causing hyponatremia, but rotavirus diarrhea can also cause hypernatremia. So when you have excess of water losses, but not as much of sodium, then you would develop hypernatremia. So gastrointestinal illness, acute gastroenteritis, that is actually the most common why you would develop hyponatremia or hypernatremia, depending on what you are losing more. Are you losing more salt or are you losing more water? So that is one group where water depletion is there. And we talked about the non-renal free water losses. So gastrointestinal losses like vomiting and diarrhea being the most common. The next common is pulmonary, which is through hyperventilation, being tachypneic for young kids, and skin losses in the form of burns, sweating, phototherapy. These all will be non-renal free water losses leading to hypernatremia. When we look at renal free water losses, there could be a number of reasons. As a nephrologist, and as an intensivist, we deal with acute tubular necrosis, ATN, quite commonly. And when you are in the polyuric phase or the diuretic phase of ATN, then you lose a lot of water. And that is how you could become hypernatremic. Post-obstructive diuresis. You have a patient with posterior urethral valves, and you insert a Foley's catheter or insert a feeding catheter tube to drain the bladder. Post-valve ablation, you would see polyuria. As a result of that, you have to watch for hypernatremia at that point in time. Osmotic diuresis, especially in patients with high glucose, you could see hypernatremia. Diuretics, it's funny. We say loop diuretics and thiazide diuretics both can cause hypernatremia, but loop tend to cause more hypernatremia and thiazides tend to cause more hyponatremia. And then when we talk about renal free water losses, besides the renal issues, either we could have a decreased arginine vasopressin or a secretion, which is in the form of central DI, or if the hormone is secreted well, but is not acting on the kidney, then you could have nephrogenic DI. And then the low water intake itself, especially young infants, newborns, patients who are cognitively impaired, who do not have enough access to water, they all can develop hypernatremia. And finally, when you have hypodipsia, that means you don't have the feeling to drink as much, then also you could develop hypernatremia. So these are all the causes when you have water depletion. But when you talk about solute excess, that means there is increased solute as compared to increase in total body water. And that would happen in case of salt supplementation in the form of sodium chloride. Sometimes you have bicarb supplementations, TPN, if the sodiums are not appropriately managed or prescribed, and seawater drowning. They can all cause hypernatremia. As we said, the two most common causes of hypernatremia are the gastrointestinal losses. And as we said, rotavirus diarrhea could be one of them, or if there is vomiting or nasogastric drainage. The urinary water losses, we have disorders with impaired urinary concentration, and that includes diabetes insipidus or osmotic diuresis. This table actually covers more details about different conditions which we need to keep in mind when we are talking about urinary concentration defects. So to divide these, this is central diabetes insipidus, nephrogenic diabetes insipidus, osmotic diuresis. And when we talk about central diabetes insipidus, it is congenital in the form of holoprosencephaly or genetic causes for that. We have acquired reasons for central diabetes insipidus in the form of tumors, post-cranial surgery, CNS trauma that can all cause acquired central diabetes insipidus. When we talk about nephrogenic diabetes insipidus, either it's congenital, it could be X-linked in the form of XP28 chromosome abnormality. It could be autosomal when we talk about the aquaporin receptors, or it could be part of other inherited disorders like Bardet Biedl, Bartter syndrome patients. A number of drugs can cause nephrogenic DI, which would be lithium, amphotericin, foscarnet, ifosfamide. So again, you have to keep that in mind if your patient is on that. Sometimes electrolyte abnormalities like hypercalcemia, because the body is trying to get rid of the extra calcium, you get rid of the extra sodium along with it, and and then you become polyuric, and then you would have hypernatremia related to that. And same way with hypokalemia, it can lead to hypernatremia. We talked about some of the renal diseases, obstructive uropathy, sickle cell disease, which can all cause hypernatremia. Now, as we learned about the 5 steps for hyponatremia management, with acute hypernatremia also, you have to see and follow a stepwise approach. You have to see whether the symptoms are because of acute rise, and then what is the rate of rise of the sodium value. In cases of hypernatremia, neurological symptoms occur as the water moves out of the brain cells, leading to cerebral contraction. So imagine there is hypernatremia, that means the plasma osmolality is high. So if the osmolality is high in the plasma, the water will move out of the cells into the plasma to make it more normal. Same thing would happen in the brain. The water will move out of the brain into the plasma. And that is why the brain cells will contract. The symptoms could be non-specific. Irritability, restlessness, weakness, vomiting, muscular twitching, typical what we say is a high-pitched cry, they can all be seen. When the symptoms are more severe, then the patient could have lethargy, coma, seizures, altered mental status. The shrinkage of the brain acutely, if it develops very acutely within 24 hours, the fluid shifts will lead to cerebral and subarachnoid hemorrhage. In long term, it will lead to demyelination and cause irreversible neurologic injury. And that is why acute hypernatremia, we worry to avoid any kind of neurological injury. Since hypernatremic dehydration is the most common reason for hypernatremia, I want to talk a few points about it. As we said, it's reported to be about 5%. Different studies go up to 15% of all dehydration patients. It is seen in children commonly because they may not have access to as much water, and especially in young infants when the breastfeeding failure has occurred. Sometimes we also see when they are replaced by high sodium foods like broth. And as we said, the water moves out of the intracellular space and the intracellular fluid compartment is compromised. This leads to the shrinkage of brain, may lead to tearing of the breathing vessels, leading to the subarachnoid hemorrhage and subdural hemorrhage as the presenting feature of hypernatremic dehydration or acute hypernatremia. This is the classical clinical signs that we see, that there is a doughy feel to the abdomen because of the fluid shifts. You see a tenting of the skin that you can see with hypernatremia. Now, when we talk about chronic hypernatremia, it happens, for more than a day. When it's less than 24 hours, it is more acute hypernatremia. If it is going on for more than 24 hours, then it is chronic hypernatremia. These patients can be asymptomatic. They may not have any symptoms. This is mainly because of the cerebral adaptation. What has happened is the brain volume could have been restored by the movement of water from the cerebrospinal fluid into the brain cells. So the body tries to accommodate, tries to adapt, tries to normalize the osmolality on the two sides. It can also generate intracellular solute, what we call as idioosmoles or osmolytes, that promote water movement into the brain cells. Because the plasma osmolality is high, the brain cells is generating these idiogenic osmoles, trying to balance the osmolality so that the water shift is balanced out as well. And that is the reason when patients have chronic hyponatremia, they may be completely asymptomatic. When it is acute hypernatremia, then the patients may have a lot of symptoms. Now, when we talk about the clinical evaluation in patient of hypernatremia, there's a few histories which are important. The GI, gastrointestinal losses, keeping an eye if there is nasogastric losses, if the patient has an NG tube, looking for colostomy drainage, then taking histories for impaired urinary concentration in the form of polyuria, having increased urine output, or having a dilute urine. Patients will give history of frequently soaking through the diapers, increased frequency of voiding, nighttime voiding. These could all indicate impaired urinary concentration. And then neurological impairment associated with the impaired thirst mechanisms or inability to access to free water will be there. So patients who are debilitated, who have a neurological impairment, they would not have as much access to water, and you would see hypernatremia. And then we talk about the breastfeeding failure in the neonates. That would be really important. After going through the history part and the clinical symptoms, the next thing is the laboratory evaluation. And I put urine osmolality and plasma osmolality as one of the first investigation in hypernatremia. But I understand not all the hospitals would have this easily available, or sometimes you may not need it. I always say that if you don't have the urine osmolality, then you have the urine specific gravity. I think it's a decent tool. And we know that if you take the last 2 digits of the urine osmolality, is urine specific gravity. So if the specific gravity is say 1020 on the urine, a rough way to calculate the osmolality would be you take the last 2 digits, that means 20, and multiply it by 30. So 30 times 20 would be 600. That would give you an idea what your urine osmolality is close to. Again, when we say 10 specific gravity, we take 10, the last 2 digits, multiplied by 30, which is 300. That is close to serum osmolality. So we know that when it's 1010 and below, that the urine is dilute, your urine osmolality is going to be low. If it is 1010 and above, then we know that the urine is more concentrated, your urine osmolality is going to be high. So if you don't have urine osmolality, still, I think urine specific gravity would give you a decent idea. And if you are able to order urine osmolality, that would be more helpful. So what does it mean then? So in cases of hypernatremia, if you have the urine osmolality less than the plasma osmolality, that means urine is dilute. The plasma is hypernatremic, the plasma osmolality is high, but the urine is still dilute. It is not holding on to the water. It is actually losing all the water. Then you would suspect central or nephrogenic diabetes insipidus. Opposite is when urine osmolality is higher than plasma osmolality. So then you basically look for free water losses, which are extra renal. So the renal mechanisms are intact. The plasma osmolality is high. The kidneys are trying to hold on to the water. And that is how the urine osmolality or the urine specific gravity becomes higher. This can be seen when you have losses from GI tract, from skin, or if there is inadequate water intake, or if there is osmotic diuresis, or if there is excessive salt intake. All those conditions will have urine osmolality higher than the plasma osmolality. So urine osmolality, plasma osmolality, those are helpful. Then BUN and creatinine, basically to see if you are in renal failure or not, that is helpful. And the next thing is the urine sodium. We get consulted about hypernatremia, hyponatremia, from different like floors, from ICU. And I can tell you as a nephrologist and as when I train or when we tell our fellows what to do, what we say is 4 tests you need. Make sure whenever somebody's calling you for sodium issues, order for urine sodium, urine osmolality. You have the serum sodium already. You have the serum osmolality. These are the key 4 parameters that you need. And that is actually helping both either hyponatremia or hypernatremia. They would help in either of those conditions to narrow down to your diagnosis. So that becomes, easy, that, okay, I need urine sodium, give me urine osmolality, give me serum sodium, serum osmolality. I think I got it. I think I can figure out what is the diagnosis. Now, how does urine sodium help? So when the fractional excretion of sodium, that is how the urine sodium would help, is more than 2%, or when sodium is being excreted appropriately with hypernatremia, we know it could be salt poisoning. But when it is less than 1% FeNA, then the hypernatremia is caused by water losses. I will make this a little bit more simple, and this flow diagram is fun. It makes things easy to understand when we talk about hypernatremia, and we will go over each arms of it. So when we talk about hypernatremia, the first thing is assess the patient. See, what the patient is looking like. As Dr. Thingavalu has said, key thing is looking at the patient. Labs, yes, they are helpful, but first assess the patient, and clinical assessment becomes the most important. So if your patient is hypovolemic, so your volume status is low, as we said, that would happen if the total body water is much lower as compared to the total body sodium. So you got this clinical assessment. Then you asked for labs. You asked for the urine sodium. So if the urine sodium is more than 20 millimoles, and this is a spot sample, then you know that this is renal losses, and the causes of hypernatremia that we discussed, which is osmotic or loop diuretic, post-obstructive diuresis, some form of intrinsic renal disease, these will be the likely reason. You go on the other side, when the urine sodium is less than 20, then you have extra renal losses in the form of excessive sweating, burns, diarrhea, fistulae, that would all help. Going to the second arm, which is there is euvolemia, that means there is no edema. So this will happen, when there is total body water is reduced, but there may be no change in the total body sodium. That is why the patient developed hypernatremia. In these cases, urine sodium can be high, low, so it may not be very helpful. But when you see euvolemia and you see other features of polyuria and all, and if you have renal losses, then that would be in the form of diabetes insipidus or decreasing less water. And when you talk about extra renal losses, in the form of insensibles or respiratory losses. And finally, coming to the hypervolimia category, when you have the total body water, which is increased, but then the total body sodium is much, much increased. And you have high urine sodium. So you talk about sodium gains in the form of primary hyperaldosteronism, Cushing syndrome. If you're doing a hypertonic dialysis, using bicarbs, salt supplementation, they would all go into this arm. So again, you see whether you have sodium which is high, look at the clinical status of the patient, assess the volume, order the urine sodium. That would help you narrow down the diagnosis. Now coming to the treatment principles, and like hyponatremia, these treatment principles are also very similar. So as we said, first assess the volume status of the patient. Next, assess if there's an emergent need for fluid resuscitation. We talk about that in hypernatremia, yes, you need to give hypotonic fluids and all, but no, if it's an emergency, if the patient is in shock, if the patient needs fluid resuscitation, the initial fluid would be normal saline, 0.9. You have to assess the need for fluid resuscitation, which would be 0.9. You will not start with a hypotonic fluid like a 0.2 or a 0.3. If you need a bolus, you would need a 0.9 in hypernatremia patients also. Next, we assess the magnitude of the deficit of water. And we'll come to that. How do we calculate the free water deficit? Then you determine at what rate hypernatremia should be corrected. Similar like hyponatremia, you have to correct hypernatremia slowly. Now, when we do all these calculations, I have seen a lot of time that we forget about the ongoing fluid losses. Always keep that in mind, that besides correcting for the water deficit, also keep in mind what is happening on an hourly basis to the patient. Are the losses continuously increasing or decreasing? Because you have to account for that. Otherwise, you will always be playing catch up. And then as we have stabilized the patient, as we have slowly started correcting, then you start thinking of what is the underlying cause of hypernatremia. And then are there any specific interventions you can do for that? Now, this flow diagram tells you about the management, that if you have different conditions, how to manage them. So first, as we said, as you have assessed the hypovolemia, if it's hypovolemic patient with hypernatremia, the key is correction of the volume deficit. So the first fluid that you would give is isotonic saline until the hypovolemia improves. You have dehydration, the water is low in the compartment, you have to give isotonic fluids to make the compartment euvolemic. So that itself would improve the sodium a little. And that is why the first thing in hypovolemic hyponatremia is administering normal saline. And then you figure out where the etiology is. So if it is, say, DKA, then you can give insulin. If there is if you think obstructive uropathy, you may need to relieve the obstruction. If there is osmotic diuresis related to hypernatremia, you remove that. So all those offending agents need to be removed, which is causing the volume deficit. Now then, once you have corrected the volume, then you correct the rest of the free water deficit. And that is where we do the free water deficit calculation. You may need a half normal saline for that. Sometimes you need more hypotonic fluids in the form of 5% dextrose or oral water to replace the deficit and the ongoing losses. When it's euvolemia, then you have to correct the water deficit first. So you calculate the water deficit, free water deficit, and then you administer your half normal saline. If you're suspecting central DI, then you may need vasopressin. And if nephrogenic DI is being suspected, then you may need to start thiazide or amiloride. If you have any drugs causing the hypernatremia, then they need to be removed. We talked about lithium, phoscarnate, keep those in mind. When somebody has hypervolemia, then you remove the sodium excess, which is there, discontinuing the sodium chloride or sodium bicarb. If it's Lasix related, then you would need to do that. Now coming to the free water deficit calculation. How do we calculate the free water deficit? We said that, yes, if it is euvolemia, then you want to, or if it's hypovolemia, you have corrected the hypovolemia, then you need to see how much is the free water deficit. So there are two formulas that you can use for free water deficit. So the first one is the total body water, which is 0.6 times the weight times the current plasma sodium divided by the sodium, which is normal, minus 1. And you calculate the free water deficit in mLs. There is a second formula. I find it easier to remember this one, 4 ml per kilo. So 4 mLs times the weight of the child times the desired change in plasma sodium. I feel here in this formula, the desired change is in your hands. You can decide how much you want to change the sodium. In the first formula, you see it's a fixed value, like the normal sodium is 140. That is what the formula is telling you to go down to. But in the second formula, it gives you your desire. If the sodium is 160 and I only want to drop it to 150, I just say difference of 10. If I have to say from 160, I want to drop down to 140, then it's a difference of 20. So if the difference of the desired change in sodium is higher, then you will be correcting it faster. You will have a higher free water deficit calculated. And that is why, yes, these formulas are also helpful, but then you have to see what is the clinical situation, how acutely it developed, how chronic it was, how quickly you want to correct. And that is why I feel the 4 ml per kilo plus multiply the desired change in plasma sodium, that helps you calculate how much free water is you need to add on and how quickly or how slowly you can correct the sodium. And approximately we say like 4 ml per kilo free water will lower the plasma sodium by approximately 1 MEQs per liter. Now, somebody has also asked me, what if I use either of the formula? Does it really matter? If you put the same, desired change as getting down to 140 sodium in the second formula, there is only a very slight variation. For fun, when after the lecture, you can put it. I mean, you can put a clinical condition, you can see how it is. There will be a little bit difference between the two formula, but the difference of free water which is calculated, it is clinically not significant. It may be like 50 mLs or 100 mLs, which does not matter much. So if you end up using either of the formula for free water deficit calculation, that should be okay. And this is, for an example, that if you have a hypernatremic dehydration child and is 10 kilo child, is 10% dehydrated, and we said sodium is 160. So we said the free water deficit is 4 mLs per kilo. So 4 mLs times weight. And then here we want to drop the sodium to 145. So from 160, we want to drop it to 145. So calculating this becomes 600 ml. So of the total 1 liter deficit in this particular clinical scenario, 600 ml is the free water deficit. So then you do 1 liter, which is 1000 mLs minus 600 is the 400 ml is the solute water deficit. We calculate the sodium deficit to just see what is the difference that you would be doing. So if you see sodium deficit, the deficit is in 400 ml, that is where the 0.4 comes in, multiplied by being the extracellular, sodium being extracellularly, multiplied by the sodium value. So it's only 35 MEQs. And then you have the maintenance fluids. This calculation is to give you an idea. The important thing is calculating the free water deficit. Again, as we had said in hyponatremia, that these calculations of sodium don't help as much, and which is true. Same way here, the important thing is the free water deficit calculation, because that is what is important, how quickly or how slowly you want to correct. So here it becomes 2000 mLs of fluid, which needs to be given to this child. So this is the same child that we discussed at the start, and we said that free water deficit calculation needs to be done for this child. So that was the right answer. But then, the same scenario, I have kept it. What I have changed is here, of the following, the most likely complication of rapid correction of this infant's condition is to central pontine malinosis, cerebral edema, dural sinus thrombosis, subdural hemorrhage. So again, in the last talk, we heard so nicely about the foods and the fruits. You put a mango in a salty water, it's going to shrink. So that is what happens when it's hypernatremia. When you reverse it, it's going to swell up. You will have cerebral edema. So any hyperosmolarity condition, you correct it quickly, it is going to lead to cerebral edema. So that's why, again, going back to the formula of plasma osmolality, so if you correct hypernatremia quickly, it's going to lead to cerebral edema. If you correct DKA quickly, it's going to lead to cerebral edema. If you correct renal failure quickly, so if you have urea, which is high, you will get cerebral edema. And that's why in the first or second dialysis session, we use mannitol to avoid cerebral edema. So that tells again how plasma osmolality becomes important. So what we say is replace half of the free water deficit in the first 24 hours. You can also replace 2/3 of the free water deficit, but it's going to be a faster drop. The rest of the free water deficit is in the next 24 hours. You're avoiding dropping the sodium more than 15 MEQs in 24 hours. The slower, the better. The sodium needs to be followed very closely, because if you start with a half normal saline, in 4 hours, you can see how much the drop is. You can go down to 0.3 or 0.2, depending on the drop in the sodium, basically to avoid cerebral edema in these cases. Now, quickly, I would go over another case scenario, and this is a 7-year-old who had surgery for craniopharyngioma and now has increased thirst and frequent urination. No vomiting, no blurry vision, no seizures, heart rate looks stable, respiratory rate looks good, blood pressure is stable, no neurological deficit. These are the labs. Sodium is 150, rest of the labs look okay, and you have a specific gravity of 1006. So this most likely diagnosis in this condition is you have hypernatremia with low urine specific gravity. So as we said, central diabetes insipidus needs to be kept in mind. So central DI is because of inadequate production or release of ADH. It could be secondary to CNS malformation, CNS tumor, infiltrative process of the hypopituitary stalk, or neurosurgery and trauma. And then nephrogenic DI is because of inadequate renal tubular response to the circulating ADH. We talked about 2 mutations with congenital nephrogenic DI. One is the vasopressin type 2 receptor, which is seen, which is X-linked, seen in male infants. In the first few weeks of life, they may present with fussiness, low-grade fever, polyuria. They could be diagnosed in the first few weeks itself. Or the second would be mutation in the aquaporin gene, and that could be associated with various syndrome. The differentiation between the between the central and the nephrogenic DI is through the water deprivation test. Deliberately, I did not, spend too much time talking about diabetes insipidus. The key was to come to a diagnosis of diabetes insipidus. Dr. Kalavani is actually, planned for a very nice session on polyuria, and diabetes insipidus will be covered more in details there. And that's why, here I just wanted to come with a clinical scenario and say that diabetes insipidus should be kept in mind. And the central DI patients responds to vasopressin, and nephrogenic DI patients may need thiazide diuretics or amiloride with low solute diet. And this is the last case I want to show, and this is case C, because we all read, these different scenarios, that hypernatremic dehydration, diabetes insipidus, but we know that our patients are not straightforward. And here I want to share a recent publication that we had in Peds Nephrology from our ICU and nephrology colleagues. And this was a nephrogenic DI patient I've been taking care for the last 10 years. And he came in with a new onset diabetic ketoacidosis. So imagine a polyuric child because of nephrogenic DI. On top of that, develops hyperglycemia as well. What would be going on with his electrolytes? And we had a really difficult time and challenging time managing his fluid and electrolyte. And this is what we share in this case report. Dehydration was so challenging because we started with isotonic fluids, because we know this was dehydration. So we started with isotonic fluids. As we gave him normal saline, because of his DI, his urine output picked up more. And he actually had worsening hyperosmolar state. Then we used hypotonic fluid and insulin infusion to manage his diabetic ketoacidosis, and the serum osmolality dropped down quickly. So now we were on the opposite side. Finally, what we ended up doing for him was that we started him on half normal saline based on his fluid deficit and the replacement rate. And then as he was feeling better, we allowed him to drink free water. This kid could, drink to manage his thirst. He has been doing it for the last 10 years. He was allowed to drink water, and we added some potassium and phosphorus to his fluid, and we did urine replacement 1:1. So it was really challenging that, to manage two different conditions in combination. And that is what I wanted to share. And this is, we call it the both sweet diabetes and the salty diabetes happening in the same patient. definitely a headache when managing the fluids and electrolytes. So with this, I would end. This is the hospital, and I thank them for their support. And this is our team, and I thank them as well for what they support me with, and all my patients, which have been a great learning experience for me. And again, thank you, all of you, for inviting me and giving me an opportunity.
Thank you, Dr. Amrish. The art of medicine is loved by the way it is dealt. I'm sure we had truly enjoyed your session. It was an excellent case series. We have few questions. Can we take up the questions verbally?
Yes, Kalevani. Hello. Yes, Kalevani.
Yes, sir. Just one second, sir.
Thank you, Dr. Jain. It was a wonderful talk. It was a very, very difficult, complex topic. You simplified it very nicely. Good message. Thank you. I think we have to see your slides again and again to understand more.
Yeah, I thought you made my job very simple because you explained the physiology so well. So thank you for doing that.
One second, sir. The first question is to Dr. Thangavelu. Is there any absolute value of sodium below which we should correct asymptomatic hyponatremia?
Thank you, Kalevani. If at all the viewers get some information from the speakers and learn something new, reverse happens from the questions. From the questions what I received, 4 or 5 questions, really good questions which I have to think and answer. Indirectly, we are also learning. Both of us are learning. This question, anytime the serum sodium is less than 135 and the child is asymptomatic, definitely needs evaluation and correction. Sometimes it may be a very simple reason like we are using a hypertonic fluid or diarrhea. It should be definitely evaluated. The easiest way to manage is doing evaluation at the same time correcting with the isotonic fluid. That itself will correct the hyponatremia most of the time. There is no cutoff number. Any level below 135 needs correction. We have to identify the reason for it. Try to find whether there is a true or pseudo. If it is true only, then we have to identify the cause by history, examination, and basic investigation, and definitely need to be treated rather than allowing it to go to very low levels and become symptomatic. Easiest way to manage is till the cause is established, put the child on isotonic fluid, either for deficit correction or for management. Dr. Jain, anything else you want to answer? Every question probably Jain also can answer.
Yeah.
No, I totally agree. I think you summarized it very nicely.
Okay. The next question is between Ringer lactate or normal saline, which should be preferred for volume resuscitation in hypovolemic hyponatremia, or either one can be used?
Both are isotonic fluids. It's a very common question asked for postgraduate. Something like, I prefer coffee, Jane may prefer tea. Something like that. Both are equivalents. Both are isotonic fluids. So both are good choices. There are a lot of arguments in earlier Nelson, which is better, which is lesser. But in 3 situations, sodium normal saline is preferable than Ringer lactate. One is in a child with hypernatremia and shock, normal saline is the fluid of choice. Ringer lactate should not be used because it will brought down the osmolality, it will bring the osmolality very fast. Second situation, a child with liver failure, where the synthetic functions are defective, we add more lactate, that also will complicate the picture. Third situation is in an undiagnosed IEM with metabolic acidosis, normal saline is preferred because that may be a lactic acidosis where our lactate also will worsen the situation. Except these 3 situations, otherwise Ringer lactate and normal saline are equal ones. They are isotonic fluids. Now even the balanced electrolyte solution is also being used. So these 3 are isotonic fluid. We can use any one of them. There's no special choice to take either one, except these 3 situations, which I mentioned.
As Thangavelu mentioned that the sodium content and sodium in normal saline is 154 MEQs, but when you talk about Ringer lactate, it is about 125 or so. So it's a little bit still hypotonic, and that's why when it's hypernatremia, dehydration and shock, you won't want to use it. As a nephrologist, I also try to be careful with ringer lactate when you have renal failure along with it. Ringer lactate has a small amount of potassium. It's not a huge amount, but if you end up giving a lot of resuscitation fluid, you may still add a small amount of potassium to it. And that's with the other condition I try to be careful with as a resuscitation fluid when we have the renal failure part.
Kalemani, can I answer some more corroborative to this? It's
Yes,
a
sir,
common
definitely,
question.
sir.
Common
Definitely,
question
yes.
asked in exams, showing a normal saline bottle, ringer lactate bottle, how much sodium it contains, how much sodium it contains, how much potassium. There is a simple way to remember this. Normal serum sodium is 135 to 145. But in 130 to 150, we will not very tightly correct it. So ringer lactate contains lower limit of normal serum sodium, that is 130. 131 is a correct number. If you say 130, probably examiner will not fail you. Normal saline contains upper limit of normal serum sodium is 154. In front 154, if we say 150 also, examiner will pardon you. The next question comes, what is the potassium content in ringer lactate? It is extracellular, normal extracellular potassium, 4 to 5. That's what it contains per liter. So these small things will help us to remember how much potassium or sodium is available in the normally used fluids. So none of us can remember so many numbers. This will give a clue to remember easily.
That's right, sir. Thanks for the hint, sir. We'll take up the next question, sir. In dengue children with third spacing, it's hypervolemic hyponatremia, but nephrotic syndrome is hypervolemic hypovolemia. Can you explain this apparent paradox?
In both the situations, there is a capillary leak. In dengue, it's inherent virus causes the capillary leak, making holes in the vessel. When nephrotic syndrome, low oncogenic pressure, oncotic pressure, so that fluid is allowed to leak out. Both the situations, there is a leaking out from the intravascular compartment, but where it goes makes a difference. In nephrotic syndrome, goes more towards interstitials and third spacing, but in dengue, it goes mainly to a third spacing. That is why in dengue, clinically edema is not obviously identified because most of the fluid goes into either into the pleural cavity or peritoneal cavity, so that edema is minimal. But in nephrotic syndrome, significant amount of fluid leaked in the interstitial compartment. That is why we label this as a hypervolemic hyponatremia. In dengue, we don't call them as hypervolemic. Then third spacing, the interstitial space edema is lesser, so we don't label this as a hypovolemic hypernatremia. This categorization is only for a clinical assessment. This may not completely reflect the total body water. Hope my answer is acceptable. I also request Amrit Jain to.
Dr. Amrit,
I think that's,
yeah.
That seems, the exact explanation, as you said, that in nephrotic syndrome, the leak is more in the pleural, more in the peritoneal cavity, or more generalized edema is there. But in dengue syndrome, the leaks are more in the pleural cavities and also. So that seems a very appropriate response.
I think that answers the question. Next question is on treatment of hypervolemic hypernatremia.
Yeah, no, that's a tough one. So definitely, it's not an easy treatment because number one is identifying the condition. And once you have identified that this is hypernatremia and hypervolemia, the first thing is what is causing it. So as we said, is it increased sodium gains because of some supplementation? You have to identify that. And once you have identified what agent is causing it, why the sodiums are high, then you stop it. That is number one, treatment. The next comes the fluid management in this case, that are you gonna, give any kind of dehydration fluid? And the answer is no, because you are hypervolemic. So you're not gonna give, any extra fluid, but you remove the agent and then you maintain the fluid balance that you would do anyhow, like a maintenance fluid management. And that is what would correct the hypervolemic hypernatremia. So maintenance fluid management and removal of the agent, those two in combination.
Tangavelu sir, you wanted to add?
Yeah, similar. I also had the same idea only. It's only that we have to restrict both sodium and water. Here, the primary management is most important, like nephrotic syndrome. Okay, start on steroid. Renal failure, start on dialysis or renal support. So the primary management is the main management here. along with the restriction of sodium and water, depending on the edema and depending on the serum levels. There is no straight answer for this.
So the next question is, when you say acute onset, do you mean 48 hours after the onset of symptoms? Say if it is diarrhea or post-initial sodium levels.
This is really a tough question. What I felt is this one, no, this question arises, it gives us many thoughts to learn further. This application of slow correction to prevent osmotic disequilibrium syndrome is mainly applicable for isovolemic hypernatremia like SADH. There only the chronic hypernatremia occurs. Chronic hypernatremia occurs because in SADH, no edema, no dehydration. But in a situation like diarrhea and dehydration, where the etiology is obvious, this time limit may not apply. One explanation. Second explanation is, as I said earlier in the first case scenario slide, we don't aim at correcting the sodium level here. I told you we don't want to separate both the grandparents. You correct the dehydration with isotonic fluid. When you correct the dehydration with isotonic fluid, automatically sodium will get corrected. You are not aiming at calculating and correcting the hyponatremia. I understood it very late. In a childhood diarrhea, what is the reason for hyponatremia? If the diarrhea stool contains more than 150 milliequivalent, then the sodium loss is the reason for hyponatremia. That will never occur because even in cholera, it is only 90 millimole. So, loss of sodium in the stool is not the reason for hyponatremia. Actual reason is diarrhea causes dehydration. Whenever there is hypovolemia, ADH is called for help. ADH can retain only a free water. So, in addition, so it pours more free water, the sodium level goes down further and further. So here, we were earlier calculating the sodium deficit and replacing. That was a wrong calculation. Actual thing, what happened is hyponatremia is mainly because of the presence of ADH, which was called by hypovolemia. So unless the ADH goes out of the scene, you can never correct hyponatremia. How to send the ADH out? Correct the hypovolemia. Once hypovolemia is corrected, ADH will go back. Then sodium will get corrected automatically. In fact, we can call it as an appropriate ADH secretion, not inappropriate ADH secretion. If you ask the ADH, AD will say, I don't come inappropriately. It's an appropriate. There is hypovolemia. That's why I attended. It's an appropriate situation. Probably that is not mentioned in many textbooks. Nelson gives only one line. After so many years only, I could understand what Nelson tries to teach us. So here also in the same situation, in acute diarrhea, we don't bring it in the time limits. Second is, once the dehydration is corrected, automatically sodium level gets corrected. There is no need to separately calculate time interval or deficit correction. Hope I am trying to explain the answer put forward to the question.
Sir brings up a very good point about what we call as SAADH. That's what we teach as syndrome of appropriate antidiuretic hormone rather than SIADH. And I think that's an important concept to understand that one should keep in mind, that this is an appropriate response to dehydration, and that's how the ADH is appropriately elevated. And we say it's SAADH, not SIADH. So, and then when we talk about hypernatremia, about the acute and the chronicity of correction, the rule of thumb is that at least you have to address the acute situation, which is if you're in shock, if you are, severely volume depleted, you need to use normal saline for that. You need to restore the volume. Then comes the water deficit correction. Once you have restored the volume, once your patient is safe, then you can correct it slowly because the history is not clear. I mean, the question is very appropriate that you don't know when it's going on. The family may say 1 day, 2 day, 3 day. How do you know when was the first sodium it was high? I think the book said more 24 hours or more than 24 hours more for calculation purposes. But that is why when I explained the free water deficit calculation, I said we can determine it. We as clinician can determine it looking at the patient. Do I want to correct it fast? Do I want to correct it slow? If the dehydration is a prominent thing, if the patient is, perfusion is poor, then you want to give the fluids faster. But then if you have resuscitated the fluids, then the rest of the hypernatremia correction, you can do it slowly. The slower you do that part, I think you'll be always safer. So.
Thank you so much, sir. The next question is there any skin condition predisposing to hypernatremic dehydration? I think the answer is also put up. It's
Right.
ectodermal dysplasia. Is there any other skin condition which can predispose to hypernatremic dehydration?
I mean, we talk about burns, right? I mean, burns is such a common condition. So that itself causes hypernatremic dehydration. And, ectodermal dysplasia, basically the sweat glands are affected, and that's how you develop hypernatremia related to that. So definitely, sometimes we say ichthyosis also, which is again, thickening of the skins and all, those all conditions can cause hypernatremic dehydration.
The next question is a little tricky question. Would the correction or calculation to assess hyponatremia in a child with elevated blood glucose be repeated?
I think the question is not very clear to me, at least.
Second half of the question isn't clear, like hyponatremia, elevated blood glucose to be repeated. Thangavelu sir, you're there, sir?
I am here only. I cannot run away.
Yeah.
The second half of the question isn't clear.
Can you please repeat?
Would the correction
assess hyponatremia in a child elevated be repeated? Yes. There is no need to correct it. In fact, as I showed on the slide, once the glucose level comes down, automatically sodium level goes up and get normalized. It does not need any specific management. If that is a calculation given is for every 100 milligram rise, 1.6 milliequivalent fall occurs. That is a rough calculation to identify the actual value and correct the sodium. That is one way will be helpful. It is not 125, it is 135. So that way we will be satisfied. If despite correction of glucose, the sodium continues to be low, it is a bad indicator that child is going to develop cerebral edema. That means we are water loading is more, and then child is at risk for cerebral edema. Once the glucose get resolved, automatically sodium should go up. A persistent hyponatremia in a child, even after glucose correction, indicate that probably we are heading towards cerebral edema. We have to restrict the fluid so that to avoid this dilution. It's a dilution hyponatremia.
Okay. I think it answers the question. The next question is balanced saline versus normal saline.
First, I will try my opinion, then Jane can tell that. I mean, the balanced electric solution came, it was very attractive for everybody that because chloride is balanced electric solution, in a normal saline, chloride is around equivalent to sodium, 150. So large amount of chloride loading was there. That result in metabolic acidosis, of course, non-ionic metabolic acidosis. Second is renal impairment. So they brought in the balanced electrolyte solution where the chloride is almost equivalent to the serum chloride is 98. And there were many studies done, and they have not come to any conclusion whether this will be beneficial than normal saline, equal or beneficial. Rather, the cost is higher. And the benefits are not proved in the studies. I think one of the studies, I forgot the name, recent study then has indicated that balanced electrolyte solution is no way better than the normal saline. But theoretically, definitely it may be useful because the chloride content is lower. 140 sodium. Sodium is also lower than normal saline, 140 normal sodium and 98 of chloride. So that way it looked attractive, but studies have not given very clearly that balanced electrolyte solution is definitely better than normal saline. Over to Dr. Jain.
No, I totally agree on that. And I actually don't even know if there is any pediatric studies there. How much pediatric data is there for balanced saline versus normal saline. I mean, I know in ICU, definitely there are some studies, and that's mostly in adults also. Pediatric data, I do not
PGA,
know.
they did one study in Diabetic Ketosis, Jayashree et al. I think.
Okay. So yeah, I mean, I agree. I think the data still favors normal saline.
I think the next question is in Aria's formula better for correcting sodium in case of hyper and hyponatremia, or can we use the same formula for correcting both hyper and hypernatremia?
My opinion, these formulas may be good, But two problem with this formula is they're so complicated that we can definitely make errors, and that will lead to more problems. One. Second is, of course, the physiology is not only sodium. So many factors are operating: ADH, aldosterone, child's intake, child excretion. So the formulas, even though they looked very attractive, practically I have not found it very comfortable to use that. Many of my colleagues feel that it may be useful. But again, these formulas are only for one-time calculation, just for initial starting process. After that, it is only the repeated clinical as well as lab assessment and titrating that. And even in hypernatremia, as Jane said, the easiest way to calculate is 1.5 times. Whatever the calculation you do, finally it boils down to only two things. You have to give hypotonic fluid 1.25 to 1.5 times. Any formula you use, finally they end up with this. So probably this crude formula may be more crude calculation more useful than the formulas. That is my personal opinion.
Yeah. What I can add on is that these formulas, or I think they say it more calculator. So I think it is more for people who just want to put in the values, like you put in the sodium value, you put in the potassium value, you say what kind of correction you want, 0.5 MEQs per liter or so. So basically us doing the math, the calculator is doing the math for you. I think that's what the formula is.
Apps are available, free apps are available.
So that's what, that's why even I see some of the residents do it here, and they would use that calculator for easy calculation. But at the bottom of it is only for the start. It gives you the initial formula or the initial fluid that you want to start. That's what it will tell you. But ultimately, you'll have to change your fluids depending on the sodium value, depending on, whether it's ongoing losses or not. Those things that, formula is not going to take into account. I think it's a good start, but it doesn't help with the continued management of the patient. That is what my personal experience is with that. So I don't tend to use it as much. I mean, I still go the traditional way. So.
Okay. We don't have questions anymore. Probably we have a comment. Both talks by Dr. Thangavelu and Dr. by Amrish Singh. Well selected.
There is a question in
chat, sir.
Chat box. Dysmenorrhea and death in children similar to any studies. But with the good ICU care nowadays, we don't lose children following hypo and hypernatremia, but two occurs. When you go through the studies, there was one study in which I think happened in one of the top hospitals in US, 1970s, I think. Suddenly, 14 babies were brought to ER from the newborn ward with convulsions, altered sensorium. 4 or 5 died even before the diagnosis was made. And within 1 or 2 hours, they found that it's a hypernatremic dehydration. What happened is, when they were mixing milk in the newborn ward, that time probably they mixed milk, I think. Not powder, formulas were not available. Instead of adding sugar, they added salt. I also checked in our kitchen also. Salt and sugar will be kept in adjacent bottles. Both the bottles are very closely mimicking. A person like me with the cataract, when you go in the early morning, the dim light, I cannot differentiate sugar and salt. That happened. And then they brought, and 4 or 5 children died even before the resuscitation. Another 8 children they saved, I think. They proved by sending the milk for sodium studies as well as the gastric acid. They proved by it was contains around 1.5 to 2 grams, 1,500 milligrams was there. So that is one of the studies that happened about 40, 50 years ago. The inappropriate, that is accidental use of salt instead of sugar leading to hypernatremic dehydration and death. That is one of the studies. It does happen, but not to the extent which happened earlier. Because now the ICU care is fantastic with good lab support, good fluid management. Definitely many children are being saved.
There is a question, I think it would be meant for Dr. Amrish. Duration of use of tolvaptans in children's.
Yeah, that's more for hyponatremia treatments and all. And definitely, here we have not been using it routinely. I can tell you that. It's not that tolvaptan is our first go-to medicine to treat. We still wait. And only, here, as we know, it's not even like approved for children. You have to get insurance approvals and all. You have to make a reason why you would use it. So my personal experience has not been as much, but I know, nephrologists in India, and they have used tolvaptan for hyponatremia treatment, and that has been used. So
probably more of adult nephrologists use it, like pediatric population we don't use much.
Yes, adults, they use it very often, but pediatric, it's still not commonly used. So.
Okay. So how about the role of oral urea usage in children?
So that is, again, that's a fractional excretion that you do of urea. The way we are saying that we are looking at the, urine sodiums and all, and then if you have associated renal failure, then will that differentiate urea excretion between SIDH or and the cerebral salt wasting or so? That is, again, a concept which is not very clear. I mean, as we have said, some of the people actually debate the concept of cerebral salt wasting. They don't even say that, they believe that they exist. And fractional excretion of urea is, again, one of the things which is used to differentiate cerebral salt wasting in SIDH. Dr. Tengangulu, what is your experience?
I don't have, sir. I have not used it. I don't have any experience. I have not even seen anybody using in pediatric.
There is one more question. Do you have some experience using fractional excretion of urate excreted to differentiate SIADH versus CRSW?
I think that is what I answered. I think that is what...
To differentiate SIADH and CRSW?
Cerebral salt wasting.
Yeah. And I think that ends the question. I think if we are left with no more questions, I think we can wind up with the session. We had an excellent discussion and an elaborate question and answer session as well.
Dr. Kalani, I think Dr. Annamalai had one question. He has raised his hand. Just see that, just try to find out, or it's an accident.
Sir,
you can ask directly, sir.
Directly. So he can unmute himself, sir, because he's the panelist. He can unmute himself and ask a question.
Dr. Jain will answer your questions.
Regarding the SIADH, I just wanted to know, you said any cause like fever or any other stress during the admission. How do we manage such case?
So this, in fact, happened not now when we were freely using isolate P, but in early part of 20th century, late part of 20th century, we were all using isolate P. Even during our PG days, till 2000, we were using only isolate P as a maintenance fluid. So what happens is, when the child is with hydrocellular hernia admitted for daycare surgery, morning sodium was normal. The evening his sodium has become very low. Went in for hyponatremic encephalopathy and died. Few of the children died. There are a lot of reports published by Dr. Aish saying that more than 50 hospital-induced hyponatremia death. They were all fighting to change the isolate P to half normal saline or normal saline. That time, only the stress-induced inappropriate ADH secretion retained more water. That is one insult. Second insult happened in the form of, we were using isolate P where every liter added 850 ml of free water. Both put together, a lot of problem arose. So we can't control ADH. ADH is beyond our control. So at least one part we can remove. That is how people started using isotonic fluid rather than. That is how isolate P, after 50 years, it was an emperor. After the Harald-Sager formula was ruling the world for 50 years, it was removed and then it was substituted by isotonic fluid. And that is the reason now that's not, it needs to be treated like any other hyponatremia. But nowadays we don't see very frequently. Even in our hospital, we don't see very frequently because most of the time we use isotonic fluid only. We never, most of the hospitals removed isolate P from their cupboards. Hope I answered your question, sir.
Thank you, sir.
Anything else you can add?
Thank you, sir.
Yeah, here we use isotonic fluid. Now the question does arise that should isotonic fluid be used in all circumstances? And that is where we quote the meta-analysis, which was published in Pediatrics a couple of years ago, and then Journal of Pediatrics. And it makes it clear that using isotonic fluids as maintenance fluid, it should still be in certain conditions. So ICU when critically sick are there, when you have post-surgical patients, those floor patients, if there are, we know hospital admissions, it could be stressful, that could be their isotonic fluids. But then it also tells the meta-analysis that they should still keep in mind certain conditions where you are not going to use isotonic fluid. Because a lot of time happens that trainees put isotonic fluids now without considering if the patient is renal failure or whether the patient is hypertensive. So there are conditions that you would not use isotonic fluid also. I think that also is important to remember. Yes, I think the standard of practice is isotonic fluids, but then we should also see what is the clinical diagnosis and see if the patient actually should be given a little bit hypotonic fluid or the regular maintenance fluid that we talked about. And the meta-analysis does talk about what are the exceptions, which renal failure and would be part of it.
Thank you, sir.
If we have no more questions, can we wind up the session, sir? Thangavelu, sir.
I think everybody wants to go on. We don't want to stop.
Probably the subject has been made interesting. It was actually a volatile subject, but it has been made interesting.
I think it was really nice for both of the faculty to have even so much interest. Unless they know more about the subject, they cannot teach. Their basics have been really good. Probably Sodium also will come and ask both of them to find if it is right in the right proportion or not. I think they have gone so much into sodium levels and abnormalities in sodium and how to manage. Probably if there is any problem, probably like they will get more queries even in the middle of the night. I think they have to share their email and phone number too, so that people can disturb them. I take this liberty to ask them to share their number or email, but it's just for a joke. But if they have any doubts, probably through IPNA or through Kalaivani, you can get the queries answered by the stalwarts. I really thank Dr. Kalaivani and thank the faculty. I'm taking too much time. Okay, thank you.
Thank you. Thank you, Gauri.
Thank you all. Thank you.
Thank you, Dr. Amrish. Thank you.
Thank you.
Thank you. Thank you, sir.
Thank you, ma.
Thank you,
Thank you, sir.
Thank you,
Thank you, everyone.
The next session will be on July 13th, sir. It's on Wednesday on hyperkalemia.
Okay. So going to...
The invite will be shared soon.
Okay.
Thank you. Thank you.
Right. Thank you.
Thank you, Dr. Jain, for your very nice inputs.
Thank you, sir.